We are live.
Okay, thanks.
Neerav,
No, I'll tell you. Request you to start. Thank you.
hello everyone, and a very good afternoon to all of you. Dr. Reema Goyal, your MOC for. I'm the director and consultant at Vaishnavi Nursing. I welcome you to this wonderfully organized International Conference 2020 and our organizing chairperson, Dr. for this amazing conference. Excellent and wonderful 2-day. We have the main conference with on adolescent health of this conference. But with academics, let me introduce all of you. Dr. Anu, she is the director and consultant obstetric and gynecology care center, Gurgaon. Next, Dr. Yukti Vadhavan, she is a fertility consultant at La Origin Gynecology, New Delhi. Next, please. Dr. Mary Ann, she is the pediatrician and gynecologist at St. Mary Kumari District, Tamil Nadu. President Nagarkoil Obstetric and 2016 to 2018. These are the co-MOCs with me for today. Now moving ahead with our academics, coming to our first session on a very important, that is polycystic ovarian syndrome. It's increasing day by day just because lifestyles of every person, not only adolescents, health risks to for lifelong. So we have a panel topic PCOS in adolescents. To moderate the session, I invite my moderator, Dr. Sneha Bhuyar. She is the chairperson, study on FOGSI 2019 to 2021. She is the president, Yavat Gynecological Society from 2007. We welcome you, ma'am. Dr. Kiran Agarwal, she is a Robson Gynae at Lady Harding Medical Sucheta Kriplani Hospital, New Delhi. President of Indian Menopause Society, chairperson, Adolescent Committee. I welcome you, ma'am. Now, for the panel, we have with us to introduce our experts. Big name, Dr. Jaideep Malhotra. Ma'am needs no introduction to today's. We all know that she's a big name and name in FOGSI, in Obs and Gynae Society. Everybody knows her. She is president of FOGSI and president of. She has given a new to the maternal health by her program. Recently, ma'am has launched a new app. We all know, and she is of Atmanirbhar App Challenge 20 credential, and we all must feel. And the list goes on of her achievements. Welcome you, ma'am. Next, please. Dr. Lakshmi Srikhande, Director of Shrikhande Fertility Clinic. She is the chairperson designate ICOG, vice person ICOG, national corresponding editor of Obstetric and Gynecology of India, President FOGSI 2012. We will next, please. Next in the list, we have expert Padma Shri Dr. Malvika Sabhar, the president of DGES, that is Delhi Endoscopic Society. Recently taken over as the president of Delhi Gynae, and she is a renowned endoscopic surgeon. Welcome you, ma'am. The next expert with us is Dr. Rose. She is the vice president family planning 2018 to 2020. The member of South Asian Council International Planned Parenthood PF 2017 to 2002. She is a fellow and member board of governing council 2018 to 2020 and 2014. Welcome you, ma'am. Next, we have Dr. Sangeeta Yadav, Director Professor and ex-head in charge of adolescent endocrinology in Department of Lana Azad Medical College, New Delhi, Joint Secretary of CIAP 2019. Welcome you, ma'am. Next, please, Dr. Sadhna Gupta. Next expert, Sadhna Gupta. She is the Director and Gynae at Jeevan Jyoti Hospital Center at Gorakhpur. Representative to SAFOG 2018-20, ICOG Governing Council 2015 to 2020, editor of Journal Obs and Gynae India 2018 to 2020 and 2016. Welcome you. Now the next in our list is Dr. Suchitra Panda, the consultant of Department of Obs and Gynae Hospitals in Mumbai. She is president. She is the past president of FOGSI, COG 2014 to 15, chairperson AICC RCOG to 2021, president ISO 2020. Welcome you, ma'am. And the next in the list we have Agarwal. He is young and dynamic cosmetic dermatologist and at W. Pratiksha Hospital of A Derma Science Center in Gurgaon. Dr. Biplav. So I welcome moderators for the session. I would like Dr. Sneha Buyar to proceed with the session. Thank you.
Thank you, Dr. Rima. Introduction. Good afternoon to all of you. I welcome you all for this wonderful conference on adolescent health. At the outset, I would like to congratulate respected President Gandhi, Vice President Agarwal, who has conceived the conference and who is the main force behind this. You, especially Dr. Ragini, Chandan Kachru, Dr. Sampath, Dr. Girish, and the whole team conference who is taking to make this conference a big success. Our today's discussion is in adolescence. As you know, it is the childhood to the immature child gets transferred to a responsible mature, and that's the reason we have seen as well as psychological changes in individual, increase in weight, deposition of body parts, especially breast and butt in females, hair different for different sexes, for starting of menstruation is the main event in this age group. Of course, the psychological changes, more shy, concern about her looks. The boy becomes outspoken, have attraction for opposite. All these changes, significant changes, but This is just the transition to know what is normal and where it becomes abnormal. Talking about adolescent PCOS, diagnosis itself is challenging because the normal ovaries, it overlaps with the characteristics of or diagnosis of PCOS. We are having a challenge for diagnosing PCOS in our. So, to supposed to do is we have to this PCOS at the earliest during adolescent phase. It's that is why so that we can the earliest and minimize the long-term sequelae. The incidence is 6 to 8 of PCOS, and that we should avoid using under or over diet. We have to do evidence-based for PCOS in adolescents, though not PCOS, still earlier at risk to diagnose. And that is why we are here to discuss all this. So let us go to the first. I think Dr. Malvika, you, 13-year-old girl, she is a mother to your clinic. Her menarche only 9. The mother is appearing irregular cycles. Pattern is 4 to 5 days, 60 days. Her BMI is, she has mild acne, no other medical or symptoms. She got her ultrasound own just by the suggestion of the and the ultrasound findings are shape of uterus, both multiple follicles, and now she started PCOS. So how is for this, and how would you tackle her as well as woman? Dr. Malvika.
Doctor, much. I hope I'm audible.
Yes.
Firstly, congratulations to you and the whole team. And Dr. have picked up a very nicely. I can see the panel seems to be extremely good topic. Now, 13-year-old girl, only 9 months post-menarche, and cycles which are irregular, borderline high. So it's borderline high and nothing more. Mild acne is there. So the is that we all do realize that be over-diagnosing wherein it could just be a normal. So it is very important to and daughter both together. It's a time where all the children are alert. They have been counseled in the schools also as to expecting even before they start their periods. Very well mentally attuned to that. This girl who's having irregular, where is having regular periods. So she the mother and she's worried about it. So you have to tell them what, explain it to them, regular period she should expect, but at the same time also sensitize her for some about overweight. That's number one. Underline at this point of time that she's overweight.
BMI high. That
it is high.
Is the BMI. What? So we talk about normal BMI.
So 0.5 to about 23.4. So for this girl, we would say that she should be sports to have more out with the increasing era of screen vision, etc., and a lot of work. The little babies also sitting on online. They should be encouraged for sports and told about the normal way they should have. In fact, it's so important to share with you. Even my grandchild knows. I put on a little weight. I better not even talk to them about junk food, etc., etc. Make the patient aware. That's important. And also tell them the downside. If they were to put on weight and they were a problem like a PCOD, eventually older, then they can have, there are people who they see are very obese, pressure in the family, outside the family, aware of things. So
Yes.
right at the beginning,
Please opine precisely the diagnosis for this case.
this is just a puberty transition period, and the hypothalamic axis will settle down in the first, after the first initial onset.
Yes, whether you would like to go for any for this girl.
For mild axis, just leave it at that. I may
I'm
not.
not talking about this is a case, your this normal transition.
Yes.
So go for any investigation for that to you for your advice.
Yes.
Yes.
An ultrasound, wherein the ultrasound, which I would not personally
Do for her.
Yeah, I would not do ultrasound,
Yes,
because
right.
we all realize they could just be primordial follicles, and it doesn't have much importance. We just rule out the ultrasound. Under vigilance, we were having frequent periods. We must look, and other things like, her hair done, awareness. Then should be given proper guidance about her hair, and also about a vaccine. This is to them about the HPV available. You may be starting at one, be made aware about the sexuality, which is extremely important at this point. Any other investigation just besides, or a total health checkup, is abdominal pain or something, you think some kind of, worms, deworms, in case she's anemic, only then.
Yes. PCOS, adolescent anemia, and vaccination against cervical cancer. These are the three main concerns raised to the patient. So,
Neha, can I add one or two things?
The law.
I think regarding BMI,
I just want to add. I want to add one more thing, that she
comment upon the BMI.
Two things is this, that I think anemia and the thyroid, two things are to be excluded. What actually medical, in their over enthusiasm, putting the adolescent on a huge pressure that because we have to see what is in the normal, what is in the, like Dr. COVID time. So like be positive about it, and don't that you eat just we can lifestyles. I think we really gave them pressure and low self-esteem as a medical person. So we have to be like do and not over, because a little weight gain is very, very common affair. There is insulin resistance in the onset of the puberty, and acne is also a normal thing. So don't exaggerate. Always give them the assurance.
So very well, Dr.
Something.
We
Can
will
I
come
add something?
summing up this first case.
I just
Irregular
wanted to
cycle.
add as an this thing. So I just wanted to add that this is the opportunity. But number two is we do anticipate as to what is normal and how we should continue as
Yes,
person.
exactly.
That's what
We have to keep a watch.
Yes.
We have
Yes, she is at risk.
yes.
Sangeeta, they should
So
be
just to summarize, we have to tell them first, cycles during first year after is absolutely normal about it, but after 1 year, if you have a cycle length of less or more than 45 days, less than 21 or more days, or any time cycles per year, or any 90 days, that is 3 months period during her lifetime, if the girl has not achieved up to 15 years of age, amenorrhea, or 3 years after talaq, 3 years after doesn't achieve menstruation, then so whatever she has is absolutely only she should not develop PCOS to have. She has to know what is health and what is exercise to be done. Regular cycles are absolutely fine. Concomitant acne is also absolutely fine. Moderate to severe acne, that is stain lesions, face is up. They are moderate to severe inflammatory. They are abnormal and they are suggestive of clinical androgenism. Pelvic ultrasound, as we have already said, no for pelvic ultrasound in it has to be done after 8 years of menarche. Okay, this confusing picture what already received. Okay, so we with the next case to you.
The second case is the 11 student has presented 2 cycles for past 6 months in the coaching class. She's having normal for which lasts for cycle length varies between 15 to 80 days. She had menarche 5. She has no acne or hirsutism. Gaining weight, and she's gained 3 kg. Thyroid is normal, B6. Clinically and biochemically, we do not have any evidence of anemia. Thyroid TSH is normal. Even her sugars were screened. What do you think? Like we would be diagnosing her with investigations you would like to do, and how?
Dr. Sangeeta.
Yeah. She's 17-year-old and she is menarche almost 5 years.
Yes.
The thing is that she of recently she has had stroke and she's definitely she's metabolic syndrome because she's sedentary, she's gained weight, she seems to be a little because of this and sedentary behavior. But when we do the clinical exam, seems to be normal. Even her 4.2 and all the normal. Even there is no distance so far. The blood normal, and she's so that's why I said she's moving to syndrome and she's at risk. One, I know Dr. Sneha is.
There is a question.
How are you going to place her? How are you going? And do we treat her?
I would like to investigate her first. Is definite that her
all the investigations
they are given rule out metabolic syndrome in her because she's already her raised and to rule out anemia. So therefore, I would like to on DHEA and
normal. Doctor, that is
I
normal.
know normal. I'm just flowing through. And we can even do the GTT and to do insulin levels. IR that is also there. And since she's 70 and to do her ultrasound also. Main investigation.
We have just say that ultrasound should be especially
in gynecology less than 8 years.
Yeah.
Yes. And there are many indicated as far as adolescents are. One is the ultrasound, one has the insulin. What is your AMH have and PCOM and all have role in these young girls. We will keep her under follow-up because and advise her lifestyle should not be increasing the weight. She goes into and loses at least 7%. Her periods will become regular. One advice
Okay, so
give her.
Input from Dr. Sangeeta. She is a higher BMI and has stress with irregular cycles. Guidelines have adolescent at risk. Adolescent at risk, a person who like a PCOS, as you very rightly said, urge, and that is why this case is here. Next, all of us would feel okay saying that she would be a PCOS to fit her into any of the Rotterdam criteria. She's not presented hyperandrogenism biochemically, but yes, irregular cycles suggestion. So we need to observe closely. She's adolescent at risk defined, and she has features of that meet the diagnostic criteria. To follow her up and develops hyperandrogenemia. Then the combination we can calculate her person. So she needs to be counseled.
I think we are really investigating her. That simple is an oligo and hyperandrogenism. This is the polycystic ovary, and we are going right. Recommendation bonds DHEA
And even
she is having
nothing is indicated.
Yes. I would like to have, because she is in coaching, something I good at, like suddenly it is not oligoanovulation. Sound for the endometrial pattern and to rule out anything to like a PID or it is better always application. We cannot, we have to see to give this message to do so much for a simple polymenorrhea. Not at all either evidence nor she is in coaching class. Next, study hard. We have to be in class and we stand the situation.
Can I say something?
Anybody else to comment? Clearly,
I would like to say at this stage, we don't really have to not even ultrasound. She has not been yet diagnosed with these. She doesn't have any clinically, put it. Also, we just need to counsel her. That's do any investigation for this girl at this.
very true. Exactly. Those are
just counseling. Just needs counseling. I mean, she and her just need counseling for the implications of PCOS. And her diagnosis should be at risk, because we really come across adolescent, they are not PCOS and they move with that label life that she is having a, and we just talk about all which are available in our armamentarium.
But she should be told about, like, she should be warned about, and just counseling is enough. No.
I would like to hear from Suchitra. Any comment from your side? Dr. Suchitra?
Yeah, I'm just trying to unmute. Yeah. Usually when there are isolated cycles and you've had a PCOS, today labeling somebody as a PCOS, I'm so scared because they've heard so much about it. It's okay, it could be an interim, but you need to be on a healthy, good exercises. See, today we are in situations, most of the metro kids in bigger places, they are on computers and they're missing their breakfast, their usual lifestyle. So, and working, there is a maid who will be cooking, bothered about giving them breakfast. Or so I think the older habits of first eating, taking, having regular meals including and nuts, as we did in our earlier years, these are the general lifestyle changes which all the girls, and for somebody who's having you, definitely we should tell them. Very, very, reassure them that you're all.
May I just sum it up?
I think it is so important today at all ages. Begin young.
Thank you so
We
much.
begin right.
Your opinion accepted. Even here is
that one of POC and see the parents. I think that's it what is needed and not again aggravated. It is already there.
Read the message. It clearly mentioned here that cycles and higher. So she's already, having these features. She's diagnosed as PCOS, and we have to just educate, as Dr. Suchitra ma'am has already said, counsel her regarding her diet and active physical exercise. Just warn her that she may have a problem. She does not have this, and that is how it is.
If I may,
Dr. Sneha, please.
the comment is that she's not diagnosed with PCOS. Look out of a patient who presents with an isolated hirsutism, anemia with regular cycles. We should of following these patients because patient we presented just because she got over-investigated. There may be people who are just not bothered after puberty transition. So as guidelines say that we may be combined oral contraceptive and defer her lifetime risk of developing or hyperandrogenemia and hirsutism, a body shaming problem for her. So it is the technical part that adults reassure the parents and lose some weight, but keep a follow-up later on.
But
I think
to be sensitive is very important. Patients who are pregnant.
Can I something here?
I want to add something.
Everyone, can I add something here?
Yes, please.
No, I'm just worried. This is that 17-year-old. Where is the issue? Making the molehill out of the small. She's just come with frequent cycles. I'm just wondering, looking for PCOS in her. Totally don't agree with it.
Yes.
Which we are giving because
View for posting this case.
I want to I want to reply.
Let
me tell you, we to the OPD and they say we were labeled and we were PCOS when here and they've googled and checked and everything. They're just married 6 months. They say we won't conceive. We know that we are known case for PCOS. As a child, they are so sensitive.
Yes, Malvika, and another important is that frequent cycles after 5 years. That is not the some in PCOS. So again, that's because it can happen early part of, but not so. This is just like maybe phase of which we need to just follow and dig too much deep into it.
Dr. Kiran has taken this case just example because how people judging themselves, how they are diagnosis, how they are coming with reports, and that is the reason this case here for discussion. We are supposed to counsel these people, supposed to counsel these girls that this is just transition and what problem, how she has to sort it out with lifestyle modifications, but under surveillance. Okay, so next case. This is the same. She comes to you after 7 months, studying 12 every day. You have explained lifestyle changes. She has followed almost 3 to 5 kg of her weight. Now she is in 12th standard studying and not exercising. On her weight increased to 28. Features of hyperandrogenemia. hairs on the lip, few hairs on the lower abdomen, also acne and prolonged cycles, 50 to the cycle length. So what investigation you're yeah, Sadhna, Dr.
Yes, thank you, Sneha. Finally, with that girl, which we suppose, I think that is not anyway. I suppose she is having the typical picture of period cycle, clinical sign of this, and this is the time to. And she's you 8 years after gynae. I think not 8 years post gynae. We ultrasound, but the very focused. Actually, what ultrasound has got in always abdominal ultrasound, ovarian volume, and there must be follicle about 4. That we should be very strict about the normal follicular pattern, polycystic pattern. As far as it is covering the oligo and hyperandrogenism clinical signs, so we have a high. We can almost say that this patient is into the PCOS. Now it's to actually start with all symptoms. Still, I don't testosterone because it is always have this thing acne and this hair growth pattern mostly. Then I think is the hyperandrogenism. I'm not a testosterone. Some people might disagree to it. Vaccination is very important. Glucose is very important. And on something related, you be the non-classical adrenal hyperplasia or the any adrenal, we go for the ultrasound for the adrenal. Actually, PCOS is a diagnosis. We have to exclude thyroid, to exclude prolactin disorder. We have a now the close watch. The family history also that the family hypertension is also not, because that puts the girl developing metabolic syndrome. But to frighten her, do the insulin. I don't do it because insulin glucose is a bit normal in the adolescent age. Postprandial or the 75-gram glucose is okay. So we exclude order, we exclude non-classical hyperplasia. If there is thyroid, again I will go for the, that is the issue. Patient COC, non-mineralocorticoid, anti-adrenoid, anti-COC for 2 to 3 months actually corrects the body. It increases sex globulin, it decreases the ovarian production, and it the cycle and it minimizes the bleeding. It actually corrects the pathology of the PCOS. I want that most. Not the so many things in you will have cancer and you will not prevent and you will die someday. Now, and we have to be very, so she is going in love or some man and want to compete in the need. Understand? So simple COC. अब बेटे जरा खाने पीने पे ध्यान. Have to ask क्या मिलता है मेस में. What do you have in your mess? Keep healthy nuts. We have to aim out, not over pressure. You snacks are there. इसको लिया करो. So that's the thing which I usually these girls.
Okay, very.
Can I add?
Yeah,
See, I just would like I would like to mention one thing to what Sadhna has said. Estrogen profile in these girls frankly help your clinical diagnosis. Or an SHBG, what is it going to do? No. And total and free would lab giving you the proper free testosterone really doesn't make sense. Yes, what very helpful is the lipid profile. the prolactin, the thyroid, and challenge test instead of doing a fasting sugar and post meal. But I think you must remember that if this put on low dose hormones, then that they're contraceptive pills. Low dose hormones, because the moment you pills, the mothers they start their, and then the girls start thinking, oh, why are you talking? So you can tell them that these are low dose. The current pills that are available, a smaller amount of estrogen, and they've got if the acne and the hirsutism, then you can use something with the ciprofloxacin can be given. But you have to tell them that these need to take them over a longer period of time for a follow-up. If you don't call them for a follow-up, show them that you're caring for them, because otherwise the gynecologist I have seen in 3, there is a patient who's come to me and do the investigations all over again. The doctor just picks up androgen profile, waste of money and too much of anxiety. Look at the previous investigations that are done, which are really relevant rather than
Exactly.
Can I add something?
Please.
She is 8 years of menarche. Guidelines says that within years of menarche, ultra indicated. So we should not go towards, and she is already having the manifestation of clinical hyperandrogenism. So hormonal profile is not indicated. Is 28. That is why the guidelines has focus on lifestyle modifications. I know it is very easy to say, but we have, and it is lifestyle modification and lifestyle modification. Science has clearly says to give them the SMART goal, that is measurable, achievable, and time bound. So within 6 loses 5 to 10% of her cycles might become her own. We should not judge COCs at the first instance, especially when her BMI is. When you counsel her, when you your paper the proper things, that if you are not able to lose weight in 12th standard, she is having, she is under too much of stress, but the weight loss be given to her and guidelines mentioned about the exercise target in this. Even at her home only she can gain the SMART goals for exercise. She should have SMART goal. She should focus on weight loss. If she's, and if she's so much concerned that, because what you said, irregular cycle, having less than 8 cycles in a year, jump on prescribing this girl. If she is not able to, if she comes from a cultural background where that she should have monthly cycles in her, then yes, after ruling out contraindication on COC.
Sneha, there is very important when these patients come. Important point we miss out all these is, and what is a complaint of this girl? Size, social factor, part of these clinical symptoms with the hirsutism, the upper growth of for obesity. You see, we don't completely jump into telling her other stuff. Should be counseled, and I would like to see Stuart telling us specifically that if you see these 6 months to develop.
Yes.
The growth of 0.5 centimeter, she should be counseled. It will take you 6 months at least. Those vellus hair. It takes time. Which factor is troubling her at the time of very important. And in this case,
Can I add? Here? I wanted to say, because we are here now having hyperandrogenemia signs and something which is going to bother hair growth is something which is, and I will have to put her COC, which is important for me, at least 6 months for her to come down. And once the androgen be some kind of a cosmetic treatment or something which you'll have to, then later. So I mean, I would put her on COPD along with lifestyle.
Exactly, only for irregular.
That is the time when now psychology are coming, and this is a tender and sensitive age. So we need to also
positive body image.
Good weight loss.
Let me clarify. It is 60 days, hardly 6 to 7 cycles a year.
COCP.
And so, and as very rightly said, she has hirsutism, troublesome symptoms she has, and that is the reason we have to start.
What do you think about?
We have mentioned here, they are you can go through FSH to be done only in amenorrhea. Ultrasound, as we have already said, it is not. So these are just enlisted, but it is not to be done. So this is just a list put when to do and when not to be done. Minimum investigations are only this: TSH prolactin, 17-hydroxyprogesterone, GTT, especially as Sadhana ma'am has total testosterone, but confirm we have to do total testosterone or androgen index also. We need, if at all we want to have the doctor.
Neha, we just have to
So,
also, please, Sneha, if I can just interrupt you. Pursue response, and if they're done, great. But we must keep in mind, we've done that 17-hydroxyprogesterone. Now we can have a patient coming in, yeah. So we don't jump, keep in mind, and ask the girls, though I don't do anything per se, I do ask them anything different in your, clitoris enlargement or something. Subtle signs of a late onset. We do ask them, but not at the first visit, maybe.
Yes, very true. So I have very nicely found the lifestyle modification or restriction and exercise regularly is the treatment. Though we have to take care of irregularities, the hirsutism described already.
I would want to
Use of
sensitizers.
Of course, the prevention of long-term sickness be the aim of our management. Yes.
I would also like to add on that mental health issues have also her anxiety because and all these, because that kind of we do for heads like home, we can work up on those, like what are the resilient, more prone to, what are her. So even that has to be done simultaneously. Really have a very low. We must, otherwise our behavioral work, our lifestyle will not work. So we have to address them and support them with family, along with the family support, be participatory also. So that.
Dr. Sneha, why we think is very weak, right? And is very weak mentally. They, like every human being, up with the stress, and we into the stress. So that like pampering or soothing. We have straight as professional. This is the thing. You will have the see what happens like the 3. You get the spontaneous resumption. This is the healthy way. It is not all for everybody. So I think always thinking that the people mentally, I don't. They are doing a really strong in the people.
Neha, latest guidelines along with physical, the psychological be given a lot of importance. US quality of life tools are We just have to download and questionnaire based studies, because it has clearly mentioned that anxiety and their quality of life, we have to assess importance to their body image. And most of the girls are not sexually. Psychological health also has to be, and if appropriate, we have to refer means specialist doctor.
Okay, so weight reduction, life COCs. So elaborate on COCs. I think Lakshmi, you are the one.
COC can be given the lowest possible, 20 to 30 micrograms of estradiol. From there, we should start combination of ethinyl estradiol. Acetate should not be the first. She has come to you with hirsutism, COCP for 6 months, whether you want to add and not, but you have to rule out the contraindications in any COCP. So guidelines start with minimum possible dose, 6 months, and then see how, and all that you have to rule out the contraindication in COCP.
How does it help for these patients? What? Once again, we go back.
Regular cycles, if the circulation decreases, so it definitely helps her hirsutism, it regularizes her cycle, and it improves her quality of life, her body image. I mean, it helps.
Okay.
Very important point here also.
Yeah, please.
For ovaries to become less bulky ovulation. So what happens to the ovaries? Yes, that's the ovaries.
Yes.
And there's a they are most worried about putting on weight with hormones, but we have to tell them that overweight, it's just it'll go off if they're doing regular exercise.
Just 1 or 2 kg weight gain.
That bulkiness, the ovarian, which has happened because of the high. Now, when you are prescribing the it is leading to suppression of all the follicles, and of course, the also goes down, and the follicles, Zika cell hyperplasia, which was there, and it definitely helps in of the symptoms. So, Kiran?
Yeah, thank you, Doctor. Now, this case is just presenting that we encounter in our clinics. For PCOS, she's obese, cycles, she has hirsutism. She's moving on from gynecologist, and sometimes she's been given 9 months, sometimes she's given a spironolactone, she's given with cyproterone. Everybody advises her something, only lifestyle, she's not able to lose weight. So I would like to ask, how would we start for her, the questions and the concerns, how long we give a particular COC patient at 16 years of age, how long can we give her a combined oral contraceptive, which one, and metformin in the background of, give her isolated metformin, and what would be the, and the second question would be, who would tell us about the cosmetic management. Dr. Rosa, please.
Yeah, so this case, which is already 9 acne score, that means she's really androgenic area. So we have given, we talk about lifestyle, oral contraceptive pill. Now, if to her, which has got a low dose estrogen, hyperandrogenia, so I would always one anti-androgenic for the time being. We talk about drospirenone, which is good. I would not like to start with cyclotron acetate, which was mentioned earlier, thrombosis. So if I would of ethinyl estradiol with a dose would be like 2 milligrams equivalent to a spironolactone, also be helpful in reducing number one, and her hirsute with outside the vicious kind of nodules in the that she has. Now, if suppose give her 6 months, let's see if this reduces or not. Lifestyle management, your OC pill hasn't worked for this girl. That is a time that you think about giving to decrease her weight further on, or add in like in form of an insulin hormone, or you could even this will wait again and see if these two decreases the weight, her suit or whatever it would be. That's not. We could add. There is a time that I would like to call gynecologist, because you see, treating people with us gynecologists, we need to have it. So I would like to involve an endocrinologist at this point and try to give her something which is strong in her hair, which is growing up with a height. And at this now, here is a case that if she I'm giving her an OC. In adolescents who do not have regular menses, and the problem that they take a history is just hair. So we have a score above the lip, breast, behind, everywhere. That is her problem. We would like to give her an however, if she is actually, I would like to add on an OC to her, just because of sterilization if she gets pregnant. I would like to add on, and we can add on as per the latest guidelines 2018. Those should be, I would say here, endocrinologists see that which androgenic treatment would be best suited at that stage.
How much at a time, at a stretch, you would feel that you see with your dose now?
No problem in giving a continuous. Have been shown that you can give a continuous. That will help around later on, like to get married and get, for her pregnancy. So for me, I would say time.
How frequently and what would you like to?
I mentioned it would be 6 monthly effect, because as I just mentioned previously, the thick hair, pigmented hair, months. Now another thing in mind that whatever hair, we cannot remove that. We are going to new growth of hairs, and she should be told the remaining hair that she has, she needs laser or waxing or whatever. So what these are doing actually is going to prevent fresh growth of hair during counseling.
Dr. Rose, Dr. Biplab, come in, please.
Yes.
You want
Kiran, I just wanted to mention 2 things. Obese, and I would also facilities permitting involve a nutritionist, because though we tell them, nutrition can give them a more proper thing. If not, we can do the same. Meal pattern is very important. And the mother should be told that the entire family to change the pattern instead of only focusing on that girl. Remember, she's obese.
Yeah, she's obese.
Her BMI must be on the higher side. And I would like to say is if the endocrine describes aldactone, remember all is through the liver. So in those cases, I'm cautious when I'm giving her the COC. Definitely do a liver function test and call for a follow-up. And aldactone, patient with a prescription of aldactone for 3 years, she was taking it. And when I asked, I said, oh no, I felt better, so I didn't go back. There has got to be a warning that with finasteride particularly with the liver, so therefore do not use it for a period of time, 6 months to a year. And once they're completely off, then actually go back to the COCs. Let them have it.
Yes.
Anti-androgens, we need to look at the liver, need to look at the metabolic profile. Patient is coming up with her symptoms. Dr. Biplab, please. What would, is he there? Dr. Biplab?
Till he comes, Dr. Kiran, there apps which are available on the, and they are very good diet apps. Can himself, she herself, see how much calorie she is consuming. She can herself calculate the deficit and how much is the per day. So this smart generation can take help of the gadgets and don't feel like going to a dietitian.
Yeah, I would like to add here to give a guide. So the guidelines for gradual loss. We're not going to give her advanced, we have to, so it has to be absolutely good. And 5 to do a lot of
I just want
Yes, can you see?
I wanted to add.
The family should be diet. The whole family gets involved in the diet.
Yeah, the emotional support is very important.
You know, if one person is obese, if a child, the parents are going to be obese.
Because they non-medicals, they knowledge of the calorie, their intake and expenditure. Of course, the calorie rich and calories. So we are the ones who are supposed to advise not to the girl alone, family, as Suchitra ma'am has already said.
Why is it so important?
That's what I had stressed about.
And they can gadget, the apps, the technology.
Family therapy only then useful because only then behavioral. But then we must have to be very careful. The pendulum towards Rosa, so you have to tread a because they already have a low. So we have to see that to get into that, and then we have related to the diet. So we have to be conservative about that also.
Thank you.
That is ready.
Yes.
Using insulin sensitizers for weight reduction.
Please.
Yes, thank you so much. I'll just give you a broad overview as in these patients in clinic. There are two varieties. There are people who would come to us and we would sort of, ask them to meet a gynecologist. Now, the biggest challenge that I face even today, the importance of discussing and, making the patient aware about potential cosmetic, it's still very marginal. Resonance is that the parents are.
Sorry to interrupt, ma'am. Only please.
Is about the parents being focused on the potential infertility, ecological issues, whereas most of the are far more worried about what's on the outside. The other challenge that we face, why this is important, trying to have a separate conversation, especially with younger adolescent patients under, just so as to make them understand the may not really be in a to them, formally or informally, that listen, my really, putting me off and my esteem is going down. Secondly, the child that why home remedies are not important. The problem with acne and hair end up with a lot of pigmentation and scarring later, which cannot be treated perfectly. So as the child is told that, doing or, plucking your hair or topical products that may not be approved, it can lead to larger complications. What is very important is to treat aggressively, in the sense that the fact that the child or the adolescent has, so we have to treat the acne. Misconception that a lot of parents carry them that these are symptoms because, which may not really be the case. Onset of PCOS might have tendency or even physiological that child. So treating the dermatologically, whether it is topicals or discussion, is extremely important. To make them aware how the whole concept of a selfie, still the concept of filters, compounding the body dysmorphic disorder syndrome. Yeah. So that is from a cosmetic or a dermatologic perspective.
Thank you so much, Dr. Biplab. To the last case, here we have a 18-year girl with amenorrhea. She has had her menarche at age, irregular signs 4 months intervals, and now she's for last 5 years. She has no symptoms or signs of pregnancy to rule out, no significant drug, but her family history is very significant. She is obese, diabetic. What is your diagnosis? You have this, her weight 80, height 147 centimeter, 38.4 centimeter, waist circumference as well, but acanthosis nigricans, and her blood pressure at present 80 millimeter of mercury. What is and how do you management?
Obese, so I mean, really rope in endocrinology, she needs, but just because we how to lose will be really difficult. Clear case of metabolic syndrome.
Concerns first you are supposed to address for this girl.
Yeah. Lifetime risk, how to explain her risk of hypertension, diabetes, insulin resistance, how to tell her about the endometrium because her cycle length is very 60 to 90 days and sexual and emotional health. So she really needs a multidisciplinary approach in managing her and her future both.
I think, you know,
yes, ma'am.
That I think here we must involve in, we cannot have an app here somebody because we need to have a calorie, and in the calorie restriction diet, how much you should have. Now, if you tell her you have 12, she won't understand that. So, a nutrition calculate, and here again I mentioned having a proper meal starting in the morning, breakfast with some cereal, fruit, and a glass of milk would be good, and carrying a her frequent meal. Here there would be a big role of adding an. I probably would. Today's the kids, you know, they do love the colas, the chocolates.
Please wind up. We are running short.
The exercise, and for the I wouldn't straight away start cirrhosis for her. Probably give her progesterone. 5 to 7 days every cycle regularly. It will see how, because she's a clear-cut profile.
Can I add here,
Ma'am, please.
Yeah, but I to go correct. This is a date where a multidisciplinary approach. So we just can't say diet. Diet has to also go ahead a lot because of she's syndrome. Long the ones she is likely candidate for all kinds. Not very in her early 30s only she will have other issues also. So I one where you can't lose track. You guys very emphatic endocrinologist in place, get a nutrition and get a good physician also in place. Very important. And she because she has, and it's not, I'm now going ahead and telling you that where there are two future generations.
Yes, very true.
So
thank you so much. And the message we wanted to give in some who are obese PCOS alone can help. Hello. Can improve the cyclist, the ovulatory problem maybe. To prove this further, the testosterone by twofold and the SHBG level, and they also help in the hyperandrogenism. Serum insulin levels also decrease. So that weight loss, if done very correct, to 12 weeks itself, it can show that diet and lifestyle model of active physical exercise, as all of you have suggested, is the mainstay of the treatment, and that we have to stress on these first. The role of medications is short of time. I think we have to panel this, but as we are always stating, diet and active physical, and then the medications we have at the earliest diagnosis, manage them effectively with evidence-based management, as all of you have suggested. Modification is the mainstay of, followed by appropriate medicine for that particular symptom, worrisome, and of course to rather minimize the long-term sequelae. I'm so happy all of you contributed so well, especially my mentor Chitra Pandit, Dr. Jaideep, my friends Dr. Rosa, Dr. Sadhna Gupta, Dr. Malavi, Sangeeta, and Dr. B. A wonderful interaction. My co-moderator, Dr. Kiran, and I thank you, all of you, once again. Thank you so much for your wonderful.
Thank you, Sneha and Kiran. Panel.
Thank you, ma'am.
Thank
you, ma'am, for a wonderful this very important topic, and I hope doubt are being cleared off, and we are very clear message for the viewers, attendees, so that we don't underdiagnose our adolescents. Thank you so much.
And Sneha,
very much.
Cases.
Yeah, very good.
Also,
Lovely to see all of you, Rose.
Zone,
Lovely meeting you.
Now moving ahead,
Very much, very well.
this conference. We would like to move ahead with the ceremony, and I would like to invite Kachru ma'am and Dr. Girish Mane sir. Dr. Chandan Kachru, she is the consultant and adolescent health specialist at Hospital Gurgaon, and she is secretary of this conference also. Of Udan project for adolescent Obs and Gynae Society. We welcome Dr. Girish Mane. Next, please. Dr. Girish Mane, he is Adolescent Health Committee FOGSI 2021 and secretary of this wonderful conference. So, now over to Dr. Girish Kachru to proceed with the inaugural ceremony.
Namaste everyone. Namaste everyone. Myself, Dr. Girish Mane, Health Committee FOGSI. I extend thanks to all of you, and I invite chief guest, the guest of honor, all the chairperson, panelists, delegates for this for adolescent health e-conference, empowering adolescent in the diversity. Friends, we are lucky. It's the unique conference on its own till the date, and I am feeling really proud of this grand event in the role of organization. Friends, सभी faculties जिन्होंने अपने panel में adolescent boys and girls की जिंदगी जीने के बहुत अच्छे राज बताए, सहारे बच्चों का भविष्य उज्जवल होगा, देश का भी भविष्य बहुत उज्जवल होगा। इस बात पर मैं सभी faculties के सम्मान में दो पंक्तियां गुनगुना गौर से सुनिएगा। बातों में जिंदगी राज है, आपकी बातों में कुछ जिंदगी राज है, आपसे भी खूबसूरत अंदाज है, आपकी में कुछ. All the faculties and all the panelists and everyone for this function. Further, on behalf of the organization, privileged to invite today's chief function, Dr. Suzanne Sai.
I'm delighted you. Namaste.
Welcome. Namaste. India. And now you are in of everyone's dream, that is India, right? Maybe what madam. Now I invite today's guest of honor, Venkatraman Chandramouli, the scientist from World Health Organization, Switzerland. Sir, please. Namaste and welcome. Thank you for your gracious presence. An opportunity to invite special guests for today's event. Ex-director of AACC, Bakul Parekh, president of Ayush Gupta, who is president-elect of AS Chawla, president of Mandakini Mek, chairperson Meera Agnihotri madam, who is president of WW, Dr. Sharda Jain madam, general secretary forum, Dr. Rajesh Mehta, who is advisor for WHO, and Dr. Sharmila Niyogi, who is a regional ID. Thank you so much. Welcome all of you. Now, friends, the time to invite the dynamic and of FOGSI, Dr. Alpesh Gandhi, sir. Thanks and welcome, sir. I take privilege to invite a group of people who work this e-conference under the aid of the Vice President of FOGSI and Secretary of this conference, Dr. Ragini. So they are none other than the members of this conference. So here comes Ragini Agrawal, the organizing chairperson, organizing chairperson again, Dr. organizing chairperson, Dr. Ashok, chairperson, Dr. Savita Singhal, chairperson, Dr. Chandan Kachru, and organizing secretary along with me, organizing secretary, Dr. Shakuntala Kumar Kautam, who is co-organizing secretary. I also invite the other team, Dr. Ajay Arora and Dr. Prem Lata, Dr. Kumar, and national coordinators, Dr. PM Jain, Dr. Mala Srivastav, and Dr. Vaisha Vaste, the joint Jyoti Malik and Dr. Anita Sharma, Abhishek Goyal, Dr. Surit, and the co-treasurer of this conference. Then the convener for this slide, please. The program, Dr. Basab Mukherjee, Dr. Rajat Thakur madam, Dr. Sampat Kumari, coordinators, Dr. Meena Samant, Dr. Rohan Palchetkar, Dr. Suzanne William, the president of GOGS, Kiran Arora madam, the secretary, Dr. and president IIP Gurgaon, Dr. Sunil, and secretary IIP Gurgaon, Anurag Singh. I welcome all of you. Next slide, please. I welcome the office bearer of Gandhi sir, Dr. Shanta Kumari madam, elect, and Dr. Nandita Palchetkar, president, then the vice presidents of FOGSI, Dr. Atul Ganatra, and Dr. Ragini, Dr. Ramani Devi, dynamic honorable secretary general of Jaideep Tank sir, then Dr. Madhuri Patel, joint Shah, Dr. Who is treasurer, and joint treasurer, Dr. Welcome all of you. Then I welcome office bearers, Dr. Parul Kotar, vice chairperson, and Dr. Parag Vinay, secretary. Welcome, sir. Then the guests who are on the advisory board of Dr. C.N. Purandare, the past president of respected Dr. Chandravati madam, past president madam, Dr. Rishikesh Pai sir, Teja sir, Dr. P.K. Shah, then Dr. Parul sir, Dr. Raj Baveja, Dr. Sanjay Sharda Jain, and Dr. Usha Sharma. Welcome all. Then Dr. Then Narendra Malhotra, Madam A.S. Chawla, sir, who is present so far. Dr. Rishma, Madam, Dr. Parag Benewale, welcome, sir. Yeah. Friends, as we all know, 2020 turned out to be the nightmare universe. Thousands of deaths and infected cases has been witnessed, and probably this thousand converted into millions frontline corona warriors agar hamare saath mein. So it is the duty of every homage for all these corona. So may I request all of you mic on the mute mode and 1 minute in the memories of corona soldiers who sacrifice for the safety of humanity.
Dr. Mane, please.
So thank you so much, friends. Now let's move to this ceremony, that is the virtual. Islam will guide all of us life for the footage. And let's pray the Almighty for the whole mankind. Yeah, let's pray the Almighty for the whole mankind. Now I know the organizing chairperson of this conference of FOGSI, ever charming person this year, none other than Dr. जो कभी झुकती नहीं, जो कभी हारती नहीं. Madam, I to deliver your welcome speech, please.
Girish, Namaste to all dignitaries on the and of the dais, invited guests, respected seniors, dear friends, and on behalf of organizing team of International Conference, I welcome and my sincere thanks from bottom of my heart to each of you for your valuable time. This bonanza is possible only by participation and unconditional from FOGSI, GOGS, and Haro. Past 2 days, we have successful health issues and adolescent gynecology conference, which is blessed by and many stalwarts of the AHA. Awareness can change generation. FOGSI has invested one full month adolescent program this August. The high point was e-conclave There are 1.25 lakh adolescents had joined, which is a visionary president, Dr. Alpesh. This conference is supported by collaboration with their immense contribution of Chandan, Girish, Dr. Ashok, and all organizing team, and of Dr. Alpesh. We are this conference in front of you. To inform you, more than 7,000 delegates have joined. Today is the conference after 2 workshops already seen. Warm welcome to our chief guest, Dr. Susan Swear, who has joined from Australia. She is the president of the National Adolescent Health Association. Dr. V. Chandramouli, lead of Adolescent WHO. My sincere both of you for your time. My warm welcome to my day, as Girish has said the name of all dignitaries, AP, DAGF, WW Foundation, USAID, and WHO. Madam, for this, thank you so much for sparing your time. Well-organized conferences only due to guidance of my learned, first of all, my mentor. Thank you, sir, for being with me. My teacher, Professor Sharma, Dr. Chandravati, stalwarts of Kesha, Dr. Hema Dibakar, Dr. Narendra Malhotra, Dr. Rishma Pai, and Dr. Pai, who has guided me universally for this program. I welcome all delegates, large numbers, and all faculty national, specifically as we are in the PCO conference. Many FOGSI has also joined for a small. I am really thankful you and very warm welcome. I have enough word to express my gratitude. This is powered by Sun Pharma, Sonora, Spectra, and Inca, Paul, Juventus, Brio, Mankind, and wonderful meeting led by Mr. Nirav. I welcome all and enjoy the 3 days which has today international speaker from all continents. We are honored by their presence. Come to them also, and to all international faculty joined and share their knowledge. Jai Hind.
Thank you so much, madam. Thanks for the welcome speech. Now, may I invite the chairperson of this conference, Dr. to welcome and to introduce the President, Dr. Alpesh Gandhi, sir.
It is invite Dr. Alpesh Gandhi, who is president for the current year, and there is no need of any introduction. Everyone, there are few important things which I want to highlight here. That he has great leadership and on this national adolescent health. We are organizing this conference, and this he has done lot of other important events and important this pandemic, which is a very difficult for us. And service, and I invite you to presidential address.
Welcome, sir.
Yeah. Respected Chief Guest of Honor, Venkatraman Chandramouli, respected seniors, CN Purandare sir, Sharma madam, Chandravati, Mira Agnihotri madam, Madam, Baveja Madam, dear office bearer, Dr. Santa Kumari, Setkar, Dr. Jaideep, Dr. Atul Gana, Agini, Dr. Anita Singh, Dr. Madhuri Patel, Dr. Suvarna Adilkar, Tank, Dr. ICOG of Dr. Mandakini Meg Madam, Dr. Kala, Dr. Biniwale, organizing chairpersons, Dr. Hari, Dr. Promila, chairpersons, Dr. Ajay Arora, scientific chairperson, Dr. Giri, Dr. Sakuntala, Dr. Chandan, all the zonal coordinators, state coordinators, all the dignitaries, galaxy of experts, and all dear friends. A very good afternoon. I extend a warm welcome on behalf of already Dr. my Vice President and Dr. Girish Mane, a very committee chairperson, has already welcomed. I welcome on behalf of FOGSI. First of all, I would congratulate Dr. Vice President, Dr. Chandan, Gurgaon Society for this conference. I have seen the vision for this conference, declared this conference installation ceremony at Lucknow AICOG, not knowing about the worries, but this, the organizing team, excellent work, and I can say physical conference, very strong conference, very unique conference, a large dates, first conference, first time a dedicated plan on adolescent health 3 days, and for the first time international faculties. In so many aspects, this is a unique will remember for long time. I am sure it will bring impact also to my topic, adolescent health. Team FOGSI believes in my message. The best way is to lose yourself in service of others. I would like to introduce to respected international faculties. FOGSI is the Federation of Obstetrics and Societies of India. 260 affiliates over India. 38,000 individual members over the length and breadth of the country. FOGSI, the largest membership-based organization in medical specialties in the world, and FOGSI came into force in Madras on January 6. This is very proud for all FOGSI about the mission of FOGSI takes care of population of India, women from adolescent to geriatric. FOGSI encourages dissemination and education as well as research in and gynecology in India. Works to pilot and promote preventive services related to healthcare, men and children. FOGSI serves to advocate the cause of reproductive health and rights. Reduction of maternal mortality is its primary mission. And let me inform this year of FOGSI Safety First, women and FOGSians. When we Here, when we discuss about Indian includes girls from adolescent and FOGSians, their hospitals, paramedical staff, postgraduate. FOGSi also believes its responsibility to work for and to help to achieve SDG goal. India in 2030, we should try the goal as early as possible by 2025 or whenever is possible before 2030. And mainly FOGSi for the goal number 3, that is being goal 4 and SDG goal equality. SDG goal 3 ensure promote well-being for all, which begins and teenage. The youngest country of the world, about of Indian population is adolescent. About 243 million people of India are belong to group. Since adolescence is the most important age in shaping attitudes that will form the base of happy adult girl and women. They have main problem and queries. They have so many queries, but they do not know whether it's abnormal or what to do, where to go, whom to. So many questions in their mind. It is important to identify them and to provide a proper and safe platform and to get solutions for their problems. What is the impression in this about adolescence? The first picture in mind is one of the self knows is buried in their phone, to be with their friends all the time. Parents just don't understand. But this age group represents a vulnerable section of our society, one that is often misunderstood, overlooked when it comes to health, because the overall perception is healthy, they do need special attention and that are neglected. Girls, this is a very common. Their bodies are changing, they start menstruating, they are behave like adults, but often they may be still children. They do not this new phase in their lives. Our Indian society with of patriarchy and gender equality forbids these girls talking about their problems. As a result, we have confused, unwell teenagers who have guided them through this phase of life. We as gynecologists have that adolescent girls, and that is why it is the vision. We believe that prevention is, and so FOGSi has a preventable adolescent education to educate, to enlighten the burden of these young girls, confident, and to make them manage their teenage years. They need to be educated preventable adolescent healthcare, which begins from, we can say, obesity, PCOS, personal menstruation, nutrition, psychological problems, social media abuse, drug and how to say no, sexual diseases, HIV and contraceptions, the legal right protection which government provided to them, to know and safety measures and for applications and many other aspects are preventable on which they adolescent health, especially preventable health education, go a long way in keeping the clean, healthy, and progressive. high number of girls from lower and lower middle class families have no why menstruation occurs. Whether the pain, the heavy bleeding, the or the other problem, normal or abnormal, they there when they need to consult a doctor. Is to educate these girls about the process of menstruation and so they can identify abnormal and get timely help. To include boys in this, they realize that menstruation is not or impure but a natural process. Hygiene education is essential to adolescent girls before they issues like leukorrhea, genital infections, PID, as people still use clothes and homemade without proper care. Educate these young women to use of napkins, their safe disposal of hygiene during menstruation. Need to encourage safe and hygienic the adolescent girls and bring them traditional beliefs, misconceptions to improve the general awareness, menstruation and hygiene. They know how to take hygienic care of their. Our girls are to begin with a sparkle of undernourishment and add to that even a slightly heavy period. It can spell disaster for level. These girls are anemic, and when they conceive, it causes a host in their children as well. Prevalence of anemia among adolescents in one of the study 56%, and this average 64 million any point in time in India adolescent age are any. It is vital that as widely talk about as coronavirus, we all are knowing that how corona, what to do for its prevention. Day-to-day number having infected with coronavirus. Know how many girls are anemic. That every adolescent and adult aware of the symptoms and risk of anemia. Like my known for coronavirus, in level 12 should be known for, so they can rectify it on time to do a lots of activity for the hemoglobin should be more than 12. Recently started a campaign for from 15th August for more than 12 for anemia. Our aim is hemoglobin level should be equal or more for all by age of at least by 2025. The overall prevalence of among adolescents was 9% and obesity was 4.8. The prevalence of overweight was 9% and 10.5% among girls. Obesity was 5.2% in boys, percent in girls. And more study according to the body mass index, 23.9% were underweight. India sees both spectrum, the poor income groups who are small for the ordinaries. They suffer from numerous diseases, many of which are on their body, on their hairs, on the other end, children groups who have grown up on a diet are often unfit. They have diabetes, joint pains, other health very prematurely. Both managed by the right information regarding balanced diet, processed foods, and striking the right between the two. Information that fed diets can do, and educational modification as a permanent choice is vital at this where looks are a major priority. This PCOS like endemic. This is a common problem that so many are facing. Prevalence of Indian adolescents between 50 is found between 9.30 and 1.6%, and it is actual incidence is more than this. This to the issues of early diagnosis in however, due to its more manifestations like these girls do not consult but often stick with home commercial cosmetic products that work. They as well as they be made aware of this condition. Its lifetime different if overall health and body. The right kind of treatment in a time control obesity, irregular as well as many hormone regulation, lifetime modification at this age to prevent metabolic and reproductive complications. One more problem in regarding early marriages. Percent of girls in India are married before 18th birthday and 7% over the age of 15. In 2017, has declared that India has the highest number of child brides in the world, 1.5 crore. India has eliminate child marriage, early marriage by 2030 in SDG goal target of FOGSI to make an effort to achieve this at the earliest. India is planning to increase the age in India. Supports Government of India's vision. So and lack of knowledge about to early pregnancies that mortality rates in our country. The estimation by UNFPA to 11.8 million teenage in the country, early pregnancy increased risk of preeclampsia, IUGR, and related complications. Adolescents, their parents, to avoid early marriages, enough time for these girls mature physically as well as mentally, able to fully take on of married life. Recently, FOGSI is going to conduct among all the FOGSI members their opinion, which should be the minimum marriage in India. Mental health care for a sensitive issue. An estimated 10 to 20 globally experience mental health conditions. This remain underdiagnosed and treated. Half of all conditions start by 14 years. Globally, depression is one of the leading illness and disability among suicide is the third leading death in 15 to 19 years. Estimated 62,000 adolescents died in 2016 self-harm. More than adolescents living in lower or mid adolescence period for developing and maintaining emotional habits important. This includes adaptations, taking regular exercise, coping, problem solving, and learning to manage emotions. Worldwide, the prevalence of episodic adolescents aged between years was 13.6 in 2016, with at risk. Many adults first cigarette prior to the age of the consequences of not mental health condition impairing both physical and mental opportunities in lives as adults. Is an urge of numerous emotions. If a child does not have enough dealing with these emotions can become difficult. This leads to depression and disorders. To prevent this, we need for psychological well-being of the child and teach them that right to ask for help with named. We wish to represent viewpoints and stress this to the government of India to bring focus the problem age group. COVID-19 also had any group, any age group. Patients are also affected in Lancet, so that population council telephone survey significantly more young women report reflecting depression and anxiety. Misuse of social media by the surveyed is times of lockdown, especially advantage young people own devices. The lockdown opportunity for cyber violence, young domestic violence also increased since the lockdown. Other problems during this COVID-19 we have observed. So FOGSI believes that mental and prevention intervention is important in adolescents, mainly individuals' capacity to enhance alternative risk-taking behaviors, to build resilience into difficult adversities, and to promote environment and social network. Believes that supportive environment at the schools and in the community are also very important. This is why FOGSI has recently organized a program to celebrate World. We celebrated August, where 120 girls and boys attended conference, and they suggested you also please organize for our parents, and FOGSI has decided to plan Connect program, e-conclave program workshops for parents, so that the adults can be guided, they can guide and boys properly and can be provided. Government has provided to this age group, but they are unaware. In our patriarchal society, at the mercy of men. In the their fathers, brothers, all male relatives, they decide how to study or whether she should go to. This gives men and even boys a sense over women. We wish to girls by teaching them about villages. They should know are being exploited or taken, and they should know or whom to approach in such a. We also wish to teach them about that are available in our country, as well as we wish to teach them vigilance with the concept of good touch, and by teaching them how to know. We also wish to educate about women's rights and gender equality, not just but on a day-to-day basis from this young age, to respect girls, so that as they grow up looking at women as equals. FOGSI's vision is Beti Padhao and according to most, vaccinations are given to others. Most are unaware of the vaccine required during childhood. The disease of cervical cancer in to China with a huge number, 1,922 new cases accounting to 17% in AC, 68,000 deaths in 2000. India, almost global burden is in India. Spread awareness and stress the need HPV vaccine, SAG vaccine, rubella vaccine, the other required vaccines during the adolescence. FOGSI, its commitment, preventable disease of cervical cancer, unequivocally confirms the role of vaccination and its screening prevention of cervical cancer for irrespective of any caste, religion, any economical status, educational status, going to come out with treatment for the prevention of cervical cancer, which automatically include the adolescent vaccination. We wish to vaccinate girls between 10 to 14 years with 2 doses vaccine at 6 months apart. Part of the statement which we would discuss the statement and pass in committee, and then we will publish it and Government of India. Strong, long trusted partnership for many projects, population stability, quality maternity care. We have partnerships, NGOs. We are doing collaborative work with USAID, UNICEF, Foundation of India, of parliamentarian on population and we also with Government of India. FOGSI works with, and this is FOGSI's vision. FOGSI recommends dedicated adolescence is a phase transition from childhood to adulthood. Adolescents are future citizens, hence 85% of adolescents live in countries, 23% of Indian adolescents, as we have discussed, 50 by 18 years, especially in rural. Early puberty, nuclear, academic pressure, urban globalization, explosion to internet, mass media may lead to adverse influence. At the same time, malnutrition, obesity, anemia, road traffic, depression, suicide, violence, abuse, alcohol, tobacco, early pregnancy, unsafe HIV, STDs are commonly seen. Investing in their health benefits. Services and clinics may be unfriendly to this population, this young. There may be barriers of high cost, unvalued services, gender discrimination, closure, and many other problems. FOGSI recommends establishing population clinics where trained workers will provide quality health to youngsters. Their privacy and will be maintained. Care providers will be friendly, judgmental, promotive, preventive, referral, informative, and services will be provided. The mental, social, and sexual health of adolescent girls and boys will be. So FOGSI also and recommends for these dedicated clinics. So this is the FOGSI's of action. FOGSI believes that gynecology is a subspecialty of obstetrics and gynecology. Its countries need priority. Wants to advocate Government of India to include preventable adolescent healthcare education as part of the high secondary school curriculum from 9th onwards across all, to start a adolescent healthcare counseling in line with recognized university, open university, HPV vaccine as part of the immunization schedule, to advance creation of dedicated adolescent clinics in public and private hospitals, to start an adolescent help, to organize special work, teachers to educate them about adolescent health issues, mental, physical needs, psychological, adolescent, and ways to deal with. FOGSI also going to commonly ask a question book, address more than 500 questions. Our experts are going to answer this booklet, and we want to circulate media as well as we want to schools and colleges across India. We want to conduct program in different states in languages, so more and more, and FOGSI do collaborative work with a big country still unreached, underprivileged, have the benefits of healthcare, adolescent segment, which is, we can say, is unreached. With the future, we came here to say American past President Barack Obama. Let us work together for FOGSI's 20 theme and to achieve our country. Thank you very much for giving me this opportunity. Present FOGSI's vision. Thanks a lot. Thank you very much.
So much. May I request Dr. announce the winners of the free paper, research free paper, please?
Okay.
Yeah. Mr. Nero, yeah.
Already it's there on my slides here.
Shared.
Okay. Very good response. First, in this conference, there are of this conference which are unique. This time, though it's on, you can say digital, but again we have received very good, and all the participants who presented their papers. Of course, limited number to be. So first prize, we have two categories. One is less than 40. So in less than 40 years, first prize, Dr. Sela Jamal. Congratulate Dr. Sela. Next. Second prize goes to Hitansi Arora. Hitansi. Third prize, 40 years, goes to Dr. Alisa Singh. Congratulations of us. You all have work very difficult, though it was important that you all have participated. Free paper. Thank you very much for participating. Congratulate all others. Now in category 2, first prize goes to Dr. Congratulations, Dr. Rakhi. And this goes to Dr. Vijayasri. So congratulations, Sri. We have 5 total, 3 below 40 years, 2 years. We congratulate them. You all will receive it and prize at your, and we also congratulate all participated, and please continue to all FOGSI's events, conferences. Thank you very much once again.
Thank you so much, sir, for your inspiring. And I too congratulate of this pre-paper competition, and I even congratulate all participated, because to participate in such kind of competition is as good competition. So I once again of you and welcome all of you on organizing team, and I request Dr. Chandan to carry forward. Over to you, Dr. Chandan.
Thank you. Namaste and good evening to you once again. Next, I would like to invite Dr. Jaideep Tankser, Secretary, to introduce our chief guest, Sawyer, who is waiting since long. Thank you, sir. Please.
Thank you very much. It's a real pleasure and honor to introduce Susan Sawyer, the Professor of Adolescent Health, Royal Children's Hospital, Murdoch Children's Research Institute, and the holder of the Jeff and Chair of Adolescent Health, Pediatrics, the University of Melbourne. Served as a lead commissioner for the 20 Commission on Adolescent Health and Well-being, previously co-led 2 series Health for the Lancet in 2007-12. She's been actively in professional organizations that support medicine, including the Australian of Adolescent Health and the US Society of Adolescent Health and Medicine. She is the International Association of Adolescent with a tenure from 2017 to 2021. Professor Susan, I took a look at your president's message on the IAH website. I wanted to see that it began with a quote from my favorite book of Two Cities by Charles Dickens. To end this introduction with a quote from your, where you end your introduction by saying, physically by the pandemic, to and must still name changes needed in our diverse community for adolescent health and well-being. Pleasure to have you here, and the stage is yours.
And very warm regard. Namaste. I would acknowledge my thoughts of what an amazing job you guys have done. 500 people online at various sessions is quite extraordinary. And I congratulate the very large number of people in this e-conference. Particularly, I want to congratulate you, the focus that obviously as an organization, collaborators that you're working with, this focus on adolescents. I've chosen to write this talk using a quote from author V.S. Naipaul, who will know spent his adult life, but was born in Trinidad ethnicity. And making ourselves according to the ideal possibility seems to me of the life stage of adolescence, but also of the opportunity to us in the professional association, whose roles it is to potentially care for young people. I am framing this as much as what professionally as well as the stage of adolescence. To you to start with, what population professionals struggle with most? Adolescents, adults? No surprise, studies around the world demonstrates that adolescents. What proportion of global assistance goes to adolescents? Is it to the 30% of 10 to 24 who constitute the population in those countries that need mental assistance? Is it the 30% of the disease burden population contribute? Consequential amount. Actually 1.6%, withstanding the contribution of these. What in the past 10 years, what proportion of global 5-year-olds versus 10 to 9? No surprise here, for overwhelmingly the research that, at least in the pediatric years, young children. What is the benefit cost ratio? Every dollar spent advancing. A BCR of 1, good, 2 is excellent. What do you think it might be? Adolescents, most people believe it's as high as 10. And then finally, what proportion focused on adolescents? Or an obstetrician gynecologist, or a nurse who will, this is that we will come back to. As we all know, Millennium Development Goals, adolescents invisible. However, there's the new SDGs and time have a global strategy children's health, but of adolescents' health. This is the first ever been part of a global. And the UN Secretary General at the time highlighted the central of adolescents to achieving everything to achieve within the SDG. In the introduction of my role in co-leading the Commission on Adolescent Health and Wellbeing, Patton chaired, this was published in 2016, and the byline, if you like, was this generation of young adults can be all of our futures, and there is no in adolescent health ensuring they have the resources, really signalling this positive aspect, just in terms of an individual course, but within our community, in our nations. The way we think about adolescence being a brief period of time of little consequence to anything else, to now appreciating adolescence as a profound period of human growth and development, in which the assets and capabilities underpin future health and well-being, that underpin social relationships, and parenting and employment established. And in this sense, a period of turmoil, we recognize as the foundation for intergenerational health. As obstetricians and gynecologists, you about puberty just as I did as a paediatrician. But that's really all I adolescents, as important puberty is but it is only part of it. And 10 years in particular, particularly learned is the just of puberty in terms of start, pubertal cascade in terms of adolescence, but really appreciate puberty in terms of its impact on neurological development. This occurs, and I've just framed this in the green, different parts of the different stages, but that don't develop biological the development of early children. At the end of puberty, young people, smartest, strongest, fittest, will depend on that their nutritional, social and cultural environments, their biology. And obviously in terms of adolescence, on one hand, this signals the abilities that young people are able to achieve then into adulthood. But on this, it frames social, emotional regulation and informs decision-making, and particularly this notion of the decisions that young people presence of peers or in high dopamine-rich environment cognitions. And I want to share with you a lovely experiment from Larry in which adolescents, young adults and older adults behind a simulated race screen on their own, actions being to drive as fast accurately as possible. Here in terms of the accident rate, no doubt the 10,000 hours hand-eye coordination of computer games balanced the number of years spent that older adults have, so that the same in each of those three ages. What do you then think happens when the experimenters, each person undertaking this, have 5 of their close friends stand behind them silently repeated the test. I think that people would, given that they were repeating the, but no, the accident rate dramatically for adolescents, increased for young adults, but not at all for who were able to maintain on the task at hand. I find this experiment incredible in terms of helping us think the way that young people themselves think. And as was signalled in earlier delightful address, we can see here the peers and media as an uber in terms of the extent influenced by peers within on the x-axis here, just trying to signal childhood through to darker flag through and old age. And when we proximal social determinants of health, family is important across the life. Transition is from the family of one's own, family of origin, to the formation of one's own. We can see here some locations between education and take place during the adolescent years on a backdrop of the structural around community expectations of young people, particularly in India, to gender, stigma, to role of young people are not growing up in biological vacuums, but are growing up strongly by the cultures, the religions in which they are born and grow. In the Lancet Commission on Adolescence, the importance of investing in the end, by which we meant the life. We know the importance of getting life, the importance of preconception of the first 1,000 follows, the importance of early childhood environments. But in adolescence itself, pay off during the adolescent period with suicides, for example, as was mentioned. But for adolescents who choose not, for example, we know that that pays off, become much healthier as adults, fewer rates of smoking related to later adulthood. And then the triple dividend is that health who delay having children, not the marriage statistics, parenting are healthier themselves, and as more educated parents, healthier decisions such as vaccination, feeding in relationship to their children. Now, in terms of the investments, typically those of us who about matching health services to health, but in relationship to the extent and social determinants of health, we all are investing in actions that are structural actions in which young people are, and also the health risks and the importance of schools and of communities is absolutely critical. To hear of your interest in terms of support. In the Lancet Commission, we divided up all of condition health, these 9 major groups. We then basically divided countries, each of these 3 countries fall into, and India still considered a multi-burden country in terms of disease. My own country of Australia being a communicable disease country, one that is much more by physical disorders and substance use disorders. You can imagine how with increasing nationally that this health profile. So on the 2 right-hand columns here, the pattern of countries. So as I said, India, far right being for males, females to it. The panel in injury excess countries, and the 2 far left are for non-predominant countries. You can see this burden of and chronic physical conditions, which you will be discussing over the conference. But you can see this burden from infectious diseases and in multi-burden countries, also the burden of sexual and reproductive. Particularly, this is early maternal death. The formal WHO definition, as you will know, is 10 to 19 years. Increasingly, there are new views on the importance of an extended age, extending from 10 to 24. Just like a 1-year-old child, incredibly different from a 12-year-old, so too will a 10-year-old, a 16-year-old, or a 20. But we can think of that same as both a child and a youth. And it, when we think of them as a child, much more protectively than think of them as adolescents. So the language I see is really important. I tend to use the language of children and young people rather than assume adolescents are just included within childhood, even if we're using it in 19. But it doesn't define adolescence, influence, and the focus of the laws, programs intended to protect and people. And for all that, not just up until 18 when they reach adult maturity. Nothing changes as any parent of an adolescent, alone we as doctors of adolescent know. Young people need a balance of us protecting for them, as we do for young people, but increasingly also need to be and engaged to be involved actively in their own. I've played with different this diagram over my 20 clinical practice, and the point of at the bottom, most of us were trained to disease and its management. We must be experts in this and foremost, but with triangulation with these three other elements of adolescence, of a life stage, knowledge of how we work to be enhancing their health literacy skills for self-management of whatever that they might be living with. How they relate to the healthcare system, health insurance in terms of frequency, in terms of the timing of healthcare. This is all critical. The way in which health services, care providers need to orient to the life stage of adolescence. We desperately need investments. I have been India's investment in the RKS case is you well ahead of many other world, but you require capacity building in every aspect of the nation, as does virtually every country, none the least my own in Australia. We need to be investing in within the core curricula of education, all clinical science, medicine, nursing, as well. And I am delighted with the recent initiative in India in relationship to a medical curricula that includes. We are desperately investments in subspecialties, whether that's obstetrics and gynecology. I'm hearing FOGSI is so committed to do, whether that is pediatrics, whether that's medicine. Everyone who looks at people needs to have the basics to match an ability, their technical expertise, young people are able to respond to. I believe that every country needs rules for adolescents' health, and by the centres of excellence around the world, including of Harish Pemde's Centre of Excellence Medical Centre. I'm of the US, what's known as the LEAR model, Leadership in Education for Adolescents, which is government-funded groupings that support not just particularly focused on public for multidisciplinary professional masters and PhDs in adolescent evaluations that have been done of the LEAR training demonstrate that the graduates in public health as you would wish them. But as you are demonstrating this astounding meeting, and again, I really congratulate all of you who have put this together, discipline by discipline, we are orientate the skills ensuring that adolescents are no longer as neglected as they have been. We desperately are needing to be supportive of disciplinary that focus on adolescents, as well as associations for adolescent health. I also commend to you the International for Adolescent Health as a federation over any national association, and I would welcome a number of us. So asking what proportion of your training adolescents, the real thing is though, what proportion of the future Indian specialist medical should focus on adolescents? Not a question that I can answer, but the only answer is more than currently in your endeavours, and thank you for the opportunity to engage with you today. Thank you.
Thank you very much. Thank you very much, Professor Susan. What words you had after according to the ideas and your ideas. Thank you very much for a very nice address. Thanks a lot.
Thank you.
I invite Dr. Madhuri Patel, Secretary General, invite Dr. to welcome Dr. Chandramouli, Dr. Madhuri Patel, ma'am. Dr. Madhuri, ma'am.
Can you hear me? Thank you, Dr. Chandan. I'm honored and privileged to Dr. V. Chandramouli, leading the work on adolescent to health, known as in the World Health Organization, Department of Sexual to Health and Research, along with UNFPA, UNICEF, Human Reproductive Program. He has to his credit MBBS, MSc as scientist. 1993 to 1995, HIV prevention in global program on AIDS. Short stint in UN. He rejoined WHO in May 6. Since then, his focus on adolescent. Before joining WHO, he worked in Zimbabwe and India with prestigious organizations. His work included providing primary care services, preventing malnutrition, preventing responding to people with HIV, setting up a regional training and initiative like school, NGO, etc. He has to his credit WHO publication, which are evidence-based policy, program, advocacy document, and self-learning material risk evaluation tools. Countries around the world where and supported research studies, evaluation and contribute strengthen the policies and different social and economical contexts. Drawing upon these experiences presented in scores of global and national conferences. Co-authored books, newsletter articles, pieces, and over 100 articles which can be accessed TPS DRV Chandram. Sir, your dedication and your inspiration. We wish you to work for well-being of humankind, adolescents, to give them better. Due to technical snags, unable to have him virtually, will run his recorded video responses to SRH lessons in context of crisis. Thank you. Can you run the video?
Grateful thanks to the of this international e-conference. Presentation will address responding to the sexual health needs of adolescents in the context of the COVID-19 crisis. I acknowledge with thanks the contributions of Dr. and Ms. Marina in putting together 5 years after the international coalition and development. Adolescents and young people of India are living in a very different context. There are more boys and young girls and young women. There are smaller households up in a context of increased dependency. The adolescents today are also growing in different social and economic than the adolescents and young people. They're more socially connected. They're more likely in school and to complete school, growing up in a context of declining. On the other hand, unemployment and underemployment have increased. Fewer girls before the age of 18 give birth before the and rates of HIV, of intimate partner and sexual violence. The horrific see in the media indication that this is occurring and continuing is mask between states, between districts within states, districts. So an enormous amount of progress has been made. There's much, much more that needs to be done. An eminent researcher noted in a blog piece titled "The Pandemic Lessons," published in May, the huge advances we have made thus in accelerating girls and boys' education, delaying child marriage, addressing Queen Gigi Boy has noted and implied in her note, many things need to be done by many. The health sector has a crucial role to play within this. Health issues. To pay particular attention to reproductive health, has published a complex technical briefs. 7 technical briefs categorized body, my life, and my work. WHO intervention listed in the Guttmark Sexual and Reproductive Health report and further development of adolescent health supplement. The first of the 8 areas of comprehensive sexuality education. Norton Pause proposes 4 areas of. The first one is communicate messages through mass media and which adolescents have access. The teen book published is an excellent. It responds of those 18, 10 to 18, stop shop both for them, parents and teachers who need, and to of adolescents who don't online. The program is running and the information. The second area is contraceptive counseling to questions and facilitate home delivery of contraceptives. This is a response to the shutdowns and the travel restrictions in place. Third area of work is comprehensive care. Not on pause areas of action. And the Foundation for Reproductive in India is an example of trying to respond to this. It provides services to women under the age of 18 and uses a variety of means to access its services and deliver it in this context. Ago, I participated in a Mary Stopes webinar. It brought international staff from around the world. And one of the messages I took away, disruption of SRH services and services has been particularly in India. So the FRH to use digital platforms, mobile health strategies to make clinic visits to provide adolescents treatment and prevention messaging, ensuring privacy and confidentiality. And mobile services are useful. And one example of this is a foundation based in Goa, providing online psychosocial counseling, and has organized a group of volunteers to deliver retroviral therapy to people at their door. You see the one realizing change is done. Helpline, it's gathered information survey, it's advocated helplines to include adolescent issues. It has involved counselors based on services in telephonic. There are other activities being developed in terms of response as well, which I have not captured. The next area of work, cervical cancer through HPV vaccine. HPV vaccination, part of national strategy, has been halted in many countries, and these actions to be as soon as the situation in. I do not have an example on. Yeah. The last area of work, counseling and services for sexual health, including the provision of menstrual services, but this also the need to respond to LGBTQ, to people with alternative gender, to distribute the menstrual to households with adolescent girls. And as you can see, it's collected electronically to keep track of it, to see whether these products are reaching them. To wrap up my presentation, the Guttmacher Institute is a blog piece titled From Back to the COVID-19 Pandemic Risk Adolescent Reproductive Health and Rights in many. It notes that dire situation. Young people from countries have experienced poverty in SRH and there are potential negatives of the pandemic. There are three listed on this slide, and I'll just read the second one. 25% average decline in pregnancy-related care would result in an additional 134,000 major patients and an additional 3,000 deaths. These estimates are from 132 low countries. And strongly for actions to avert harm. To conclude, COVID-19 crisis is a threat to us, but it's also an opportunity to do better, to build back better. You, as foreigners, know very well to do much, much better than done to respond to the SRS. Join us, WHO, to showcase initiatives in all union territories. Join together a bank of case studies which, with experience, that we can do this. Yes, we need to. Yes, we can. We can tap into the energy and excitement in this area to respond.
Much, Dr. Chandramouli sir. I would like to invite Dr. Pramila, past President FOGSI and organizer of this conference, to introduce and Sharmila Neogi from USA. Pramila. Dr. Pramila, yeah.
Dignitaries on the dais and all dear friends. First of all, I'd like to congratulate Dr. Alpesh Gandhi, Dr. Ragini, and dear Chandan for a success. I'm to introduce Dr. Sharmila Neogi. Dr. Sharmila works as advisor for adolescents and gender in the USAID India. She has an extensive public health experience working with Population Foundation of India as joint director and technical assignment with Ministry of Welfare, Family Planning Division. She has also worked with several organizations as HLF PPT, Foundation of India, and Mary Stokes, their family planning and reproductive health for young people. I welcome you, Dr. Sharma.
Dr. Sharmila? Dr. Sharmila, are you there?
Good afternoon, everybody. The dais, Dr. Alpesh, Dr. Susan Sawyer, Dr. Pense, Dr. Chandra, Dr. with us virtually. I just want to first of all congratulate us for organizing this excellent conference on adolescent health, which is a very, very important area and across the world. I work for USAID, the health of youth is an extremely critical issue across the countries. In India, working with a number of different stakeholders this issue, we work very closely in India, both in designing adolescents as well as system implementation of these programs. We also work with civil society sector players as we feel important for adolescents through information and services. Sectors, partners, capacities for improving these access to it is acceptable to them and with choices for their health and reproductive. We have an existing MOU with which we work very closely. MOU we work closely with FOGSI to strengthen friendly health clinics that spoke about before. It has actually pushed the adolescents a little bit to the background, offers great opportunities for us leadership in their collaboration. That by enabling the aspirations of all contribute towards building a stable, democratic, and prosperous community. Thank you very much.
Sharmila, very nice words for the very positive. So next, I would like to invite Dr. Sunita, President IIP Gurgaon, to Pemde. Dr. Sunita.
Hello, am I audible? Yeah. Good evening, everyone. I'd like to congratulate for taking this great initiative for International E-Conference on Adoption in this difficult time. It is a great pleasure to invite Dr. who is Director Professor of Pediatrics of WHO Collaborating Center, Lady Harding Medical College and Hospital. He is a very well adolescent health, and he has been my teacher also, senior residency. So I would like to welcome you, sir. Dr. Harish Pemde, sir, please.
Thank you, FOGSI, and thank you for giving me this opportunity of talking center about some of the work which all the dignitaries kindly accept my greetings. Especially I mentioned Dr. Susan. And on behalf of W Center on Training and Research in Adolescent Health Medical College and Kalavati Sir and Children, I welcome you all to this conference. The organizing chairperson. Friends, our center for working for last 13 years, and we prestigious designation of WHO last year in February 2000. I'm happy to put on record help provided by the current chief guest of Susan Sawyer and the guest of honor who supported, guided, and helped or indirectly in setting up this coveted designation of the center. We established health on the lines of center at Royal Children's Hospital, Melbourne. Susan Sawyer is the director of this. And madam, we are trying to reach level near to your center in years. Dr. Chandramouli came to India. He is from India only, but he came especially in 2005 to train us in a program in adolescent health. President of that time and Dr. Ashwini Gandhi were also there. They are from FOGSI and this became the tool for the government program also. Fortunate enough to be given the responsibility those WHO orientation program modules of Rashtriya Kishore Swasthya Karyakram of adolescent health in India. Recently, we have for adolescent, this is by the name of T. Friends, currently we are working a guide on parenting the adolescent next year in the form of an app. And so, very importantly, we are some artificial intelligence based for medical practitioners. This adolescent job aid algorithms and management of common adolescent health issues. Also working on standard teaching learning adolescent health for the new medical education curriculum health, which has been in India in 2019. And Dr. Susan Sawyer also mentioned brief education part. Work with multi-specialty obstetricians experts, dermatologists, and community health experts. Very well reflected in this scientific program conference also. So I congratulate Dr. Ragini and Dr. Chandran for the international conference, and they have really showed that how to distress into an opportunity. They have done it very well. And for giving me this opportunity, working with FOGSI, and for this wonderful and very successful e-conference. Thank you very much.
Thank you, sir. Thank you very much. Your center. My special thanks Susan Sawyer, today's chief, at a very short notice to bless, give her words despite her very hectic schedule. Chandramouli sir, thank you so much. Pesh Gandhi sir, thank you so much for your other special guests. My work. Now I request all of you to stand up for the national anthem. Thank you very much. Now for the next, I would like to invite Dr. Anu for the keynote addresses now. Dr. Anu, take over.
Good evening, everyone. Good evening, everyone.
Go on, Dr. Anu.
Good evening, everyone. Thanks, Dr. Chandan and Dr. this grand virtual international inauguration. So the next session is on first keynote is on sexuality dysphoria, and I really feel honored our chairpersons. Person is immediate past president Dr. Ambedkar, ma'am, who is one of the pioneers in India. She is professor in Patil Medical College, Navi Mumbai, super specialty degree, reproductive medicine, Delhi, and she has a long account. Next, please. Next, please.
Hello, Anu.
I will request Dr. Shada. I will request ma'am. She is great leader, mentor, social worker, and great source of us. She's founder, secretary general, Psychologist Forum 2000. She has received lifetime FOGSI as well. We welcome you, ma'am. Now I will request Dr. Shadajan, our speaker. Shadajan, ma'am, please.
Unmute.
Hello. Anji?
You have to unmute.
Now, and pleasure to introduce a speaker from Australia. She is going to speak to you on sexuality. Interests are on child development, child safety and well-being, youth, sexual abuse care, and gender. Is going to today speak to you on gender dysphoria. Over to our speaker.
Okay. So much for the invitation, and you can see my screen and whether you all can hear me. All right. Okay. Okay. Thank you. Greetings from Tasmania, and the center screen is where I work at Royal Hobart Hospital. I just wanted to say a big topic, so make it simple and complex, and I thought I'd divide 4 aspects, which is understanding and then some service delivery at our center and scenarios. I'd like 20 minutes so that I can questions, we can address them. I don't think we need to define the biological or physical of hormones, chromosomes, gonads, external characteristics, secondary, etc. But sexuality really is a state of being sexual, and it's the feeling part. And sexual orientation is the gender to which a person is attracted. And looking at sexual development from this perspective, puberty as the dawn of sexuality, and and the discovery of romantic attraction, overwhelming at times, the feeling they could be confusing, and teach their own sexuality by experiences. And that one sexual orientation may be part of this whole process. There is stressful time, and in addition, it acceptance or fear of discrimination, rejection. Their own sexual orientation, few friends know, or very close to them. Technology is really coming out. And the stress can reduce by family and friends. The point, even 1948, Dr. Pomeroy and Martin organized sexual scale with inclusive heterosexuality and 6 homosexuality, and this is called with 1 to response to bisexual sexuality. Different sexual orientation really is the problem. It is just important understanding and provide and support to have that disorder or abnormality. Change sexual orientation are ineffective. I think we need to learn to that can lead to a happy, fulfilling life. All parents want the best for their children. Officials must support and enable understanding. So really, we're talking about a non-judgmental approach. Young people to focus on their tasks, their academics, their relationships, and get on with their lives. And that's all really on different sexual orientation. Moving on to understanding gender expression. I do realize this is not a very topic for India to. It is an up and coming topic of interest, and I'm sure even in India who have these ideas do not have a service to go to. At where we want to do the external presentation, name, clothing, behavior, voice. Gender diverse people are those who do not conform to cultural expectations. By transgender, we mean someone whose gender identity is not sex assigned at birth. Gender is really when it assigned at birth, so a male is, could be a cis male, female. We don't really use cis talk, but trans, those who are born female, as a male, and trans youngsters who identify as a female, trans female. Non-binary young people or even adults identify as male or female, and they can sort of move from one to the other in behavior. Gender identity, as what we talked about, biological identification of a particular female, a blend of both. Gender dysphoria is from incongruence between a person's gender identity and assigned at birth. So it's really this which can be quite difficult for people to manage. And no gender diverse, sorry, I don't know what's happening to. So diverse children are those who had an increase due to social exclusion, physical assault, homicide, discrimination. When we are trying to manage these, and transition can be social transition is the first step, process by which a person changes their gender match the identity. And this means just dressing them, dressing up as males if they're wearing makeup as females, growing their hair long, changing, using nail external expression they wish to. Medical transition is the a person changes their physical character, and this is done by hormonal, and really the principles are really that it is, we actually as professionals have to gender, the rest of it is social. If you're going to manage transgender, individualized care, which use a preferred name and avoid harm. If you prevention, we have to put it social cultural factors and requirements of the states or country in which we live. Management basically is as the first pillar. As I mentioned before, it's a appropriate gender affirming approach. And if the family is supporting a young person, there are definitely improvements. And the clinician may often have family members to develop that sort of the child's experience. And it some time for the parents to understand it. And then the extent, and the siblings find it very hard. Grandparents really take a longer time. Out of the family members, moms are more expecting, dads take longer. That's my limited experience. Definitely need a multidisciplinary approach, and we need to manage the existing and young people with trans male. There is an of autistic in some of them. They also have health problems, usually suicidal anxiety. There's family functioning. Because of that, we need to ensure that the social transition undertake is led by the child and family. It should reduce the child's distress and improve functioning. So first step is for name, preferred pronoun, child, clothing, and this transition has to be really supported, but also at school, and at least workers, the teachers, the principals, classmates, and understanding part of the whole transition. And I think this has to be the first step to do any medical transitioning. If at all we're looking at medical, you're looking at what stage the young person comes to. If it is at the onset of puberty, sometime by doing what is called as puberty, that is stage 1 treatment. This is temporary. You have to, what you have to, gonadotropin. So we use a leuprolide. It suppresses the endogenous estrogen, and by that it relieves the distress and progression of the physical changes of puberty. In trans males, you're stopping the breast menstruation. In trans females, you're stopping the voice deepening. But however, the linear gain continues. This gives the adolescent some time to and cognitively, and also make sure that they really want to progress with this medical transition. The main concern when we are giving puberty suppression is really the effect on bone mineral density. And so we do the scans to make sure they are okay. We ask them to exercise. We make vitamin D is all right. And we would normally commence at 2 when the LH is greater than 0.5, and in males when breast buds have developed, and the testicular volume in trans females would be if it's more than. That's just an arbitrary sort of decision. We go by the Australian guidelines so that we follow a standard procedure across Australia. That just makes it more comfortable for the families to know doing the same thing. Once they're on puberty blockers and they still want to go ahead, what are called the cross hormones between the ages of 15 to 16, and this is what we'll call it 2. And in stage 2, looking at is estrogen, which can be used to feminize or masculinize depending on gender we want to achieve, and this is done by inducing the onset of secondary characteristics of the desired gender. Of course, none of this is informed and legal consent. Usually we would take both parents and also a young person, and you want to assess the competence of the young person because you want to make sure that they've understood consequences and understand truly something that they want to go. Before we do a transition, we always fertility preservation counselor for all the young people. That is really done with our obstetrician. The real thing is, it is about testosterone, infertility, but what we ask whether the young person wants to have in the future, and if that's a would want to store semen by cryo, usually done through masturbation. Is stressing to the young people who do the genitalia to be male, but babies they still really we want to stress that sperm production, whether these effects are permanent is not known. In trans males, you want to also count of unwanted pregnancies. Internal organs are present. Okay. Transition, something we would consider, oh God, sorry. I'm not very good at this, I think. Surgical transition is moving by themselves. Okay, surgical transition is reversible. Not recommend it. Sometimes which is the chest reconstructive surgery undertaken after the consensus is reached between the adolescent guardians and the clinicians involved in the but genital surgery only considered after because of the greater risks which are associated with major surgery, impacts on long-term sexual function potential. Supports are equally important. The additional supports are really looking at psychology and counseling because the anxiety and depression of the whole stressful thing, but also family dynamics. We would have a social worker and advocacy really mainly looking at the in school and to support family and support groups which are really parents of parents with children with dysphoria, and they the considerably. And not considered often is the voice and communication, because voice coaching to help develop skills useful for young people who want to have or a lighter voice, and that which we do when we think it is important. Our clinical team really is multidisciplinary, and We have a nurse coordinator, the referral, and takes this because it's really important to understand. It needs a whole multidisciplinary team. It needs a doctor. So the nurse coordinator judges the referrals and takes phones, email queries from GP or the community. We have a child and adolescent psychiatrist who is interested in this topic, who will do assessment as a pediatrician. Need the medical management, usually for under the age of 15, where blockers. So specialist does counseling reservation. We have a pediatrician in our team who addresses any related queries that the families may have. A psychologist who gives some support, and social support groups with NGOs, basically social transition in schools. Would be like a young person needs oh my God, sorry. Yeah, so the program refers to our gender service.
Left, you see second option. Yeah, pray from.
Yeah. Okay. Thank you. It's moving by itself, but okay. So our P refers to our gender service. We contact the family by phone or email. Provide a info pack guidelines, and we also ask questionnaires. What happens is you want to talk at the first. If they've had a set of questionnaires to back, we also ask them to give us personal what they would like to see happening, what are the ambitions, expect from our clinic. It's easier for us to have the conversation like where to from here. And then this joint clinic appointment, we do the detailed history after looking along, do a clinical examination, puberty status, and then we come to formulation. If investigation, really it's looking at the puberty and also some baseline investigation tests, calcium, phosphorus, line study before we will refer to the we refer to psychologists, we refer to social work, schools, and sometimes we assessment, like if the child has got autism, I'd go ahead and do an autism assessment, or any, if there's anxiety. Management would transition, the medical or sometimes you would have needed if the not ready or the parents are not, if it's not thinking it's that they are non-binary, they don't transition, or sometimes have a chat, then they go back and think, and then come back when they are ready. Lots of times that you don't really have to take, and the follow-up will then depend on what is needed and according to the age of the child and where. I just given two examples to give us an idea about, say, a trans female. So a 13-year-old boy identifies as a girl, came to us, also had anxiety and inattention, was really distressed because his voice was breaking and he didn't want to be a boy, had been feeling that for at least quite some time, but had informed the family a couple of years back. So our formulation after all assessments was we did the examination, he was at puberty stage 2, and the social transition change and gender officially, was very happy with that. Went through fertility counseling, collected sperms for, And then we started him on puberty blockers. We continued puberty blockers with the young person for about 2 years. And when she was 15, we commenced cross hormones with and for the first 6 months, we continue to give puberty at the cross hormone. 1 year later, she's doing really well and very happy where she is. A second case I share with you all was really looking at a case. This is a female who had anxiety, depression, PCOS, and had started menarche, identified as was very unhappy. He had started at 12, going to be very helpful. So the at this stage was looking at menstrual and we used norethistine 5 milligrams twice a day, was in periods. We did some young persons not interested in babies, biological babies, required general counseling for the depression, anxiety, often SSRIs, I think sertraline. And this young person, after everything, we started testosterone as per protocol. He has not improved and is still struggling. And this is really mainly autism because cannot. And the improvement of mood depends also on comorbidity. So we think very often alleviated when we start treatment. A lot of the comorbidity are quite debilitating for them. So in summary, I would like to say that standards of care and treatment guidelines to provide guidance for healthcare providers. Because we know that supportive gender during childhood and adolescent can be improved. And the take-home message for I thought would be recognizing complexity and diversity. We need to aim to be respectful and supportive. We have to appreciate that all families are different. We need a skilled team, a holistic approach, and need informed consent before any medications, surgical interventions. I'm happy. Thank you very much. Happy to take any questions. I realize this topic is, but any comments or questions, and I'd also of Parmar for organizing the
Dr. Jayaka, this is absolutely a challenge for us. Yes, and as a pediatrician, I haven't never. I think it is very happy to see are getting organized in a gender in Australia. I think people need to take up, and I think people who are gender dysphoria, and if we look at a clinic of that kind, we will definitely. Then we have standard of care, as you've. You may not have plenty, but
I agree. I don't think the numbers are giving the care is really important.
I agree with you. You gave a really right to all of us who have been here live across that this is one challenge that the adolescents have to take care.
Madam, I think I wanted to. This was an absolutely new. As a gynecologist, we were exposed to this, Doctor. It was something new, so I have to congratulate this wonderful topic. And of course, you have really given a very this topic.
I just thought simple because I realize it's not. It's just sort of sensitize doctors in India. Have somebody who comes there that we can help. Yeah. Thank you,
ma'am. I have experience of one of my student who is gender dysphoria, being a trans female. He got
Having question answer, we are already very.
so it's a very
Others are from different continent of.
So I would like to. It was a wonderful lecture, ma'am. Our third chairperson for the session, Dr. Shanta Kumari, ma'am. Ma'am is the president-elect FOGSI. Ma'am has been the chairperson COG 2018 and secretary 2015 to 2017. Too many accolades to her name.
I up and go to the.
Yes. So, ma'am, you to introduce our Dr. Swati Bhave.
Thank you very much. Swati Bhave. I have to be reading in the WhatsApp group of. I wanted to know something about Dr. Swati. I can tell you her students love her. Some of her students who were her undergraduate, like Parag and all, and they were so much. She was their pediatric professor. And I think all your students love and understand your focus on the adult, madam. So she's been a pioneer of adolescent medicine. Of course, an adjunct professor at DY Patil. Has been a visiting consultant pediatrics. Sassoon's Hospital at head of the adolescent clinic, Jahangir. Was the executive director of. In fact, madam had worked as bearer and executive positions in many organization, IPA, IAH, IPD, and AP. And the most rewarding, I think, compliment you can get are the compliments from. You have been a professor from Pune. You had moved, and you are heading an NGO, and you're doing a lot of fantastic work. And it's really a privilege for you, and we can understand, what's the IAP Lady Pediatrician of the Millennium, the Lifetime Achievement Award of IAP, and the IMA All India Award. And please welcome to Dr. Swati Bhave. And I'm sure all, even the adolescents who are going to listen to your talk. Dr. Swati Bhave, can we?
I know Swati.
Can.
For 20 years, she's a. Nobody other than trained so many pediatricians and so many. Listen to her.
Thank you so much.
उनको फोन कर रहे थे नीरव वो.
Way back in 2005. Absolutely great.
Thank you. For UNICEF child abuse as workshop. So thank you, Shanta. Thank you, Sharda Jain. The Kalpesh Gandhi and bearers, Jaideep Tang, Girish, Chandan Kachu, and Agarwal, Rohit. So I'll just start. This topic, many people question that why are you focusing on girls when you are talking to obstetricians who are girls. But when I go through my keynote address, I will give you some new food of thought and challenge some of your thoughts about it. So, young girls' health, Indian scenario. Presentation, the Indian of girl child. Why is to focus on the girl child? The role of adolescent medical, by which I mean all physicians, adolescents, pediatricians, family physicians, psychiatrists, would like to add adult physicians. And the third part is all can do personally and together as health professionals. Indian scenario, the sex rate is skewed, the overall is higher in males, school drop males, the maternal mortality is better now but still not acceptable, and the violence against domestic, sexual, physical in all sectors. Gender discrimination, a child, girl, very beginning. Initially, it's a struggle with female feticide. Then in discrimination of breastfeeding and and either there is no health seeking or she's taken late to a health facility and denied costly treatment. The malnutrition continues, become substitute mothers and are taken with a high rate of school dropout, forced into child labor or domestic. And of course, we are highly vulnerable all kind trafficking and violence. Adolescents, this chronic undernutrition compounded by early marriage, teenage pregnancy, and of course, domestic violence, dowry. And what happens when even educated urban, there is societal pressure, norms. Very often, there is no follow their own ambitions. That sacrificing life is their priority as a woman. Why is this all happening? Socio-economic and cultural aspects. Age-old tradition, diva, that is preference for both. What do we have to do? We have to instead of society. And for last, through my NGO and through our IIP and IIP, we are working in primary schools. Start young, the girls are empowered, and the boys understand. Also do programs and adults in college because become then confident, feel emancipated, empowered, learn to respect women. Boys learn to respect women. Violence and sexual discrimination never stop. And the president, Jaideep Tang, yesterday had very about this. You see, this picture has a very important role to play. Now, both daughter and son equally. Affects all the women in the family. Sister, his wife, his daughters. Discrimination in the family. Sometimes women who are brought up with a particular mindset, enemies of women themselves. Most show discrimination against their daughters. If you all saw the new movie, the father's role is very powerful. He only had to fight gender discrimination, but in his own home, it is program of Government of India, Beti Bachao, Save the Beti Padhao, Educate the Girl Child, launched by our Prime Minister. Note that in addition to the secondary groups involve doctors and the tertiary groups, the Beti Padhao Yojana has very in addition to the government schemes on the girl child and a long way in promoting a girl's health. The flagship program of Ministry of Welfare was launched in 2014. Kishore Swasthya Karyakram, RK. This also will go a long way in improving agencies like WHO, UNICEF, UN work, but UNICEF is mainly for gender issues, and they have started 2018 to 20 country program, which adolescents but more on girls, health, education, child protection, that is menstrual hygiene and toilet, social mobility and for girls. UNICEF has got 3 cross-cutting themes: the gender strategy, advocating promoting equal values, and women's safety. The gender brief of 2020 shows very statistics: increased girls' reduction of number of girls out of, increasing female literacy, reducing marriage and new HIV infections. If we all continue working together, we will. So, talking about scenario, what can we as do to help this? We must activate wherever possible, whenever possible, the national programs. Only then improve the various statistics of gender in our country. I come to the second my lecture, and that is the issue in clinical practice. And sexual health is very important at national programs, and all of you are active to promote. So I'm not going to spend more time. Pediatricians are now taking good in adolescent sexual health, and in the year with the FOGSI Adolescent Committee, we brought out this book for pediatricians. And many of you, the senior people of Frank, Rosa, Parag, have contributed to this book. So when you talk of preconception care, we know that malnourished women produce who have hyperinsulinism, which increases risk to diabetes type 2 and heart disease. So what should we do? Prevent malnutrition in the girl child, prevent early teenage pregnancy, all work to prevent, which is the lead cause for all above. And what really happens when there's malnutrition and fetal undernutrition? Mass goes down, the fat mass goes down, leads to hyperlipidemia and hypertension. Increased cortisol leads to central obesity. Because brain is important, but there's impaired development of liver, blood cells, giving rise to intra resistance, and this leads to a diabetes 2 and coronary heart disease. So this is all very, very important. I want to bring a new focus. Procreation is not the only aim, as has been the theme for life. For the last 20 years, I've been for adolescent girls and young women, colleges, engineering, and medical, conduct corporate workshops for young to learn how to balance home and the career. And express one thing to me: be essential to get married. Many not to have children. Many may have surrogacy. And parents bring to me saying, Dr. Bhave, please counsel them. Marriage and children are important. So I tell them, what are the pros and getting married versus remaining single? The pros and cons of not having a child. What are the pros and cons and the laws of adoption and country? But once I've done that, the woman to have her own decision. And I request the parents to please respect the choice, even if it's their girl, and not role which society has imposing on. And I think as women, this is real. And as obstetricians, gynecologists, if we can do this, we'll have a in the society's mindset. You all know about non-communicable diseases. NCDs are the life course, conception to adulthood, and beyond in the community. All of us to have a different, to come out from the concentration of girl, healthy mother, which is of course, but also focus on making a healthy woman, regardless of become a mother or not. We need society. So now understand that early and early undernutrition cause, now it has been found that that is a bad lifestyle for NCD, and hence we have to give emphasis on the health, adequate nutrition, healthy every day, at least 1 to 2 hours physical activity, adequate sleep, which is seldom done by most of us, to toddlerhood, and doctors We should work on this. Disease, your patient has come. Minutes to guide that girl to adopt healthy lifestyle. It will be in preventive NCDs. For this audience, I don't have to emphasize among the many effects, it is not known very exclusive breastfeeding prevents coronary disease, type 2 diabetes. Communities are not aware of this. And more than pediatricians, obstetricians have a far better role to play to exclusive breastfeeding. A couple comes to you for contract planning, that is the time you can start that whenever you have a child, breastfeed. And in the first month of antenatal, care of the nipple problems and start. When you give a birth, you must have breast. What are your questions? What are your problems? Maybe model to nurse. So she, by the time she's 9 months pregnant, she's confident about breastfeeding. Postpartum breast problems, it is too. Another thing, why is it so important? In the past, when we had joint family, breastfeeding in the house. So girls are models and they didn't think breastfeeding was bad. Any skills. Today with nuclear family, breastfeeding. And I've got young couples feel very embarrassed to have the, and hence we have to start breastfeeding from IIP Women's Wing primary, telling them how important breastfeeding. In college girls, we are going to teach. So by the time she gets married and she is a champion of breastfeeding. NCDs are also called lifestyle diseases. And though we allopaths, our science has beautifully explained principles of healthy lifestyle. And if you can, we will not get NCDs. WHO has identified 4 factors: physical inactivity, diet, and in adolescents, and harmful use of alcohol. And start screening of NCD onwards. We pediatricians NCD metabolic syndrome at the age 8 or 10 in obese adolescents. All need to start screening for NCD very early in life. So what can we do to keep young girls? In pediatrics, we say that you never lose an opportunity. And if the child is ill, at least. Similarly, I would urge, don't lose an opportunity whenever any girl comes to you to give anticipatory guidance, preventive counseling on various adolescent health, which will help of an adolescent girl. Issues in young girls today, undernutrition, multivit mineral deficiency, especially because of zero size eating disorders. And we all must remember, certain things are done only in the adolescent period. Density is established puberty and growing period. And once not done, this mineralization in adulthood. And the woman has a long time to come. Unhealthy because of zero figure, lack of impact of media. All these are the medical don't require only pediatricians. We want guys to help us to tackle these issues. Psychiatric illness start in adolescence. These are often missed because nobody. In the presidential address, I was very happy to see FOGSI on mental health issues. The are very few. There's a stigma of professionals. And you all know what is just now of a celebrity of psychiatric. So we all have to be psychologists. And every patient, after discussing the medical problem, to discuss his mental health. And how do we need to know that we need, and as very beautiful Sawyer, the adolescent brain, frontal cortex, which does not have, and most of the adolescents are working limbic system, and the dopamine reward pathway is extremely addictive. And all what you see to sexting, pornography, junk, drinking and driving, substance abuse, thing is related to dopamine receptors. Receptors are common. So what do we know our young people? That pleasure and happiness. Pleasure, dopamine. Happiness is long serotonin. So do things which happiness. And this is a slide that dopamine, which is from haldi days, is very quick to go away. And dopamine, which you get talks, music, dancing, your dog, cat, not just your boyfriend, your mother, your sister, playing outdoor, good music, drawing, painting, oxytocin, serotonin are more rewarding, and you will not do unhealthy behavior to seek dopamine on Facebook and social media. People take obesity very lightly. Young girls today, when we talk to them, they say, with our body image, I don't mind looking fat. To explain to them, it is not just obesity is a disease. It is every organ of your body, and be aware that the moment the child is, you start taking care so she does not. I keep this chart in my clinic, so all of the obesity means. We always track the growth and BMI from 2%, and any change in centile, the person is getting overweight, and we start to prevent obesity. Charts which for Indian population free. We also have BMI downloaded free. So pediatric monitoring growth and thing, and also doing immunization. It's my request to OBGYN that BMI charts to your adults and can look whether they're underweight or undernourished and going towards fat. You always do HPV vaccination, but spend 2 minutes on asking the immunization, because in adolescent there are specific TDAP, MIS, MR, and any childhood vaccination. If we help in immunization, our immunization of young girls will certainly go up. All know about the metabolic syndrome resistance, and screening of young is really important. In fact, in my college, I asked all the girls and boys, do your abdominal girth 80 centimeters or more than 90 centimeters into obesity, and you're at high risk for it. We need to use every opportunity to tell people about metabolic syndrome. You all know the complications of metabolic syndrome, right? But I would like to urge gynecologists, if we prevent obesity, we will prevent. So let's work at the prevention. You all are working very hard of the medical problems. Make you understand that acne, obesity, and the pigmentation havoc on the minds of the girl, and very often she may not explain to you what in her mind, and that's why just spend 10 minutes on every. Ask some basic questions. Are bothering you? Are there any problems in college or friends or family, or a adolescent girl who's troubled, waiting to open up to somebody, empathy, and is ready to listen? 5 minutes of conversation, she will, and maybe you will be the person, mentor, who will change her life. So please spend 5 minutes, understand. And I would just like to give you just last week or 1 month dinner, where there was a young girl coordinating, speaking on common adolescent problems, parents, how to deal with them. End of the man cannot talk to you for 5 minutes. She burst into tears. She said, ma'am, patient, through my college, through my premarital, trying to, after marriage, not getting a baby, 5 years now with great effort, getting a child, gone through a havoc. And I wish who could have spoken to my parents at that time, who could have come to college and school. And today my life would have been different. And first, we have to understand that the psychic aspects are as important as. So why my lecture? What role can through professional organization with various NGOs, and our FOGSI has excellent, robust. We all are involved in the IMA. I'll be sharing our IIT. In the year 2016, we started a women's wing, which is very active. In 2017, we brought the small little bud. And in 2018, we got young boys focusing on the issue and empowering them to help women for gender discrimination. We use these modules in many parts of India. This was launched in 2016. And because I have been the only woman from 1987 today, that is almost, I was given the honor of becoming the, and Dr. Hema Bindu from Hyderabad is the, every year our IIP Women's Wing and the presidents of IIP, the office, are honor, give us honor by attending our. This was a launch which we did. And what are the things we do? So slides which we use in this Namni Kali, we ask them to understand on the emotional development due to gender inequality, and life skills to boost up their self-esteem, teach them negotiating skills when they are in relationships. We give them a gender, we teach them about menstrual hygiene. We talk a lot about mental health and depression. Cute little images like this one. Girl, how many more people are you killing? We also discuss what is known as session workshops, where we show ads and we demystify ads. Woman is not a commercial activity. We discuss various movies. Woman is put in a very bad light. We discuss movies where a woman has a powerful role, and we say this is what woman. And we show pictures of the various women achievers in the last many decades and say this is. And now we have our own IIP General Madhuri Kulkarni. We are very proud of nutrition. We also show in various fields, and this is how that you can be whatever you want. IIP Women's Wing in 20 gone beyond this, and we have coming up with to focus on other aspects of. And on 10th September, we'll be launching. We have 3 modules: training parents and teachers, and training. And our IIP President, Dr. Bakul Par, DIP platform. A new module which is like very close to my heart is, I feel that the majority of are breaking today in the very first year of life. Young people go into marriage without realistic expectations and not what a compatible partner is, and will help a lot of young people. Gynecologists to do this as a, in addition to the medical part of, if you can do all that just for 5, change the face of marriages in India. I will just in the last 5 minutes a little about my NGO. I left my clinical pediatric practice and listen. As I did adolescent practice, that NGOs are doing wonderful work. So in 2008, I decided an NGO. Now this NGO is very, it is not the common NGO with grant employees. We are just a group of specialties, mental health professionals. These doctors are my students, are my friends. We also have parents, sports icons. We do voluntarily work and to spend time in schools and colleges in parents. We have a very strong where we train peer educators and then colleges, because as we know, peer is far better than adult to child education. I just share 2-3 slides on the NCD we are doing. We go to schools, weight, BMI, and abdominal girth, advise about NCD prevention. We have where we check their lifestyle, how many hours they sleep, junk food, social media and gadgets, and advice. We have short teaching, learning how to choose food properly, exercise, how to sleep properly, and back on alcohol. We don't preach, don't take alcohol, because they'll certainly take it. how if you take alcohol below the, how if you take tobacco below the age.
Excuse me, Dr. Bhave. We are running short of time. You only have to.
I'm just going to finish. These are last 2 slides.
Yeah.
And we have done collaboration with Global, and we had petitions to work with NCD. We have done programs in schools, and we are part of a India known as Healthy Alliance India. And we have presented the Congress with won prizes for it. Last but not the least, one doesn't work when we get recognition for awards, and our community work has been well. And I thank everybody, and I thank for giving this opportunity to share and professional work, and the which is so dismal can be changed if we all work together. Child labor and early child marriages. Tomorrow we will have girls who are working and thank you very
much, Dr. Swati Bhave. Now, Dr. Nandita Palshet come up the session. Dr. Nandita, ma'am, are you there?
Not there.
Okay, so I thank both the speakers, Dr. Anand, Swati Bhave, ma'am, for wonderful, and also our esteemed chairperson for their valuable time and expertise. So moving on to the oration session by Dr. Pire Andre from who will be speaking on developing person-friendly healthcare during COVID. May I invite our chairpersons for the first is our very dynamic and FOGSI President 2020, Dr. Second is Dr. Ajay Arora. Can I have the CV slide, please? Dr. has 35 years of experience in. He's the IAP Gurugram and the President-elect now. The next chairperson, Hotri. Can I have her slide, please? Is the Professor and Head of Obstetrics and GSVM Medical College, Kanpur. Chairman, Ethics and Research State. She's also the President of W Foundation. She's organized and she has a lot of accolades to her name. All the chairpersons. May I request Dr. Alpesh sir to start the. Dr. Alpesh sir.
Thank you very much, Dr. Yukti. I welcome all of you for this important session of conference. I welcome Professor P. on behalf of FOGSI, sir, for your accepting our invitation. It is always a great opportunity for an oration who has done extraordinary work, excellent work in this subject. He is fortunate to us as an orator. The conference has begun today. We all are waiting to hear you. Now the moment has arrived. You are going to speak on a topic, and you have also done a work on developing sustainable healthcare during the COVID. About this COVID-19, this era which has, and it is a big, and we all it. Our adolescent girls are also facing lots of the lockdown because of so many of COVID-19 pandemic, and it's a big treat to have you with us, the pioneer person, and our delegates are going to be benefited a lot. With this, I invite Dr. Ajay Arora, Professor Pierre Andre.
It is a great pleasure for me, Professor Pere Andre, Honorary Professor in Adolescent Medicine, Faculty of Bioscience of Lucerne, Switzerland. He is an author of around 170 publications and 30 in various books. He has focused on the epidemiology and lifestyle of adolescents, including areas such as health and suicide, eating, school health, reproductive health. He is Dean for Medical Education in his several years. Independent consultant in a school since 2012. Currently, he is the Vice President for Ethics in Bio in Canton of Vaud. Folded hands, I welcome Professor Pere Andre for Professor Pere Andre. Please.
Much. I feel by this Horatio or invitation. It is also a session with people since many years, including Swati Bave, and as far as I understand, Jamila from WHO and from IWH. Let me come to my presentation. Let's see. So I'm going to discuss with you how to create environment which promotes for adolescents.
Sorry to interrupt. Have you shared your screen?
Yes, I did.
We cannot to the Zoom screen, please. And click on share screen, then select.
Okay, I have clicked on it.
No, sir. Come to the share screen. Do you see the green button in share?
Yeah, absolutely. I desperately.
Okay, now window that says Microsoft. Think small windows out there. Yeah.
Is it okay now?
Please play.
And is it?
Yes, sir. Yes, sir. We can see.
Okay, we are saved. Objective for today: how to identify the care needs of adolescents, to obviously respond to healthcare, and I will conclude on how to respond to the COVID pandemic. Let me start with a vignette. A young adolescent, 16 years old, living in an RG. She does not know much and reproductive health. Her parents have made their best home during the confinement, but limitations linked with the pandemic, Indira has slipped out of it, and this night had a sexual intercourse with her, and she now fears to breathe. She doesn't know to whom she should speak. She does not know much. Vaguely heard about emergency. And I mean, this is a typical situation that you can find where in the world. Obviously, adolescents around the world, and they have commonalities, and we will discuss in 20 minutes. Adolescence is not an age. Adolescence is a process, and the main goals in this process for an adolescent are progressively autonomy and to acquire, to know what they will do, what they expect from life, to share their lives. And we have heard from Swan minutes ago on the adolescent brain. What happens during adolescence is that select to some extent selects neurons and improve the connection in these axons and neurons. What is special about the process is that it begins in the back of it, finished in front, called the prefrontal cortex, which, as we heard from, is the of the brain that enable the adolescents to take control on his emotions, foresee consequences of the. So this of the adolescent brain explains adolescents impulsive, unexpected, and lack long. And just think, when she sexual experience, she was trapped in her the boyfriend without looking at potential consequences and unprotected intercourse. So to summarize, both need a support, begin more, but on the other hand, need protection because they are mature. And in the Convention of the Right, which see the right for autonomy, at the same time the importance to be protected, to be not only from violence, but also from many other damaging. So this leads us how to respond. What is care? We have to sustain the autonomy of the patient, the young patient. And we have to be aware of the time they do not, they're not in adults. So we have to establish a way to know how to use them, where to access, whom trust, etc. This is role also of the educational to support and give them some health literacy in how to use the system, where to access, how to a trustful relationship with the doctor. There is a lot of literature on how to make healthcare system user-friendly. One of my colleagues in Switzerland made a review of the young people's perspective on friendly healthcare. Do young people themselves from a healthcare? And to review some of the specific aspects. Important is obviously of healthcare. Does anyone, a gynecologist, a primary care structure that care of the situation, give advices if it's on emergency contraception. And in my view, this is really a, as I said before, of the system, but also of the system to provide this information to young people. Another very important that was discussed by the other speaker is the attitude of the staff, especially what we communication skills have done in Switzerland since many my faculty is that for the students to train their communication and active listening adolescents who have been simulated patients. And expect from students in gynecology or to also train with the simulated adolescent patients, establish a trustful, respectful communication with adolescents. One seminal condition relation between and their doctors, obviously the issue of conflict, especially in the field of sexual and reproductive. We have to guarantee some kind of confidentiality, not to say that should be disclosed to the parents, are important during, but as a start, when you to see the adolescents, you put on the table the issue of confidentiality and let the adolescent know that by the end of the consultation, him or her, what can be said to the information and what for a limited period of time by the doctor to the parents. As mentioned by Swati, encounter with an adolescent, nutrition, a GP, or obviously from a gynecologist, opportunity to survey lifestyles that is the adolescents, how he feels, what the atmosphere, how is it going in school, eating habits, activities, peers, use of social, and obviously also the potential use of illegal or even drugs, as mentioned also a few minutes ago. Finally, even non-gynecologists as the issue of sexual health with young people, as Swati Bave, it's duty for pediatrician, and obviously it is as physiologists are concerned, it's obvious, but it's important not only for, I mean, tech issues such as do you know about menstruations or about protection and contraception, also to discuss the young girl feels about sexuality, how she foresee her emotion in this domain. Finally, it is provide an appropriate and to be flexible in terms, especially because many adolescents in emergency not expected to a problem like, for instance, um, uh, when doctors, the hospital or in clinic, they have to provide some oriented physical space, possible separate from other, such as younger children, adults, and also provide some of care. Obviously, young like to have to repeat each time. As you can review a lifestyles described before, is not something you have to necessarily in one encounter. This spread over a few encounters, and also this review will be introduced by the training why he is or interested to give the opportunity to the young adolescent to ask or to get advices, information. So in other terms, it's to involve young people in two directions, them in reflecting design or to better design healthcare clinic, for instance, is something we have done in the country when we have started. We are a clinic, but you also in young people, they not considered just as objects that have to do you explain, but to work with them and complex situations such as the one we would recommend with the young person what she thinks she could do to improve the situation. So to some, you need to adopt an approach. The adolescents respect privacy and obviously provide good care in specific areas such as SRH, important during adolescence. As I mentioned before, you can do type of context in a hospital, in a big primary care clinic. You can in school. Many schools have some of school health services. Work to be able to adolescents. I would like to that these principles have been designed by young, but have also been reviewed in different publications of notably which you can find on the internet. I would like now to turn to the issue of the COVID pandemic. A few days I had a look at the statistics in India. You have millions of people, and in India, country, including my own country, there was a focus on people because we know that all the are really menaced health by COVID-19, but to focus on we have forgotten the children and adolescents have been the during the last 6 of the COVID pandemic. What actually has happened in countries is first of all, people did not get information on what COVID is all about. Many of them have been able to go to school for some time have clearly totally or isolated from their they have in many countries go out to have sport activities at an age so important with peers and with a mental health crisis, some of them, including the fact that working in close location with sisters and brothers and parents has induced some the family. The fact in many instances the only way for them to relate to peers were to use internet, but for some of them become more and more addicted to internet. And finally, obviously, access to healthcare structures, especially for those living with chronic conditions, was very problematic. So, how can the society react in the because we know that we will have COVID another couple of, if not years, alas. And the thing we have to think about is the fact that all these consequences of COVID increase the inequity, because it's the poor families, poor children and adolescents who have access to internet have suffered probably from so that as you are also, we are discussing from WHO and UNICEF that, in fact, I live close to the headquarters of WHO. We are discussing on how FOGSI can be taken in the future to minimize the risk linked, I would say the risks linked the COVID. Comment would be to say that we work with young people. First of all, at least in my country, but as well, have been able to react and support people in facing the COVID. Some food, also people that were severely isolated. Also, I think they discuss with professionals and like me, like us, how to of young people. I'm sure develop over time new means. Certainly, as I impact of COVID on mental health, we have to think on how to make mental health clinics, structures available by young people, and mostly responding to the principles that I described. Closing probably on the long-term thematic, and we know now in observed distances, mask when needed. It should be possible to reopen schools where they have been in many, with some specific measures, obviously, etc. Another option that we are discussing with my colleague of UNICEF is use the web, expand the connection between teens and teachers, and give them some perspectives on with the COVID, to give them as well some on their personal future. And in doing so, I think we need, as mentioned also before, speakers to mobilize and national association and decision on the impact of COVID. In my view, in my country and in European countries, politicians, decision makers have not foreseen the impact, psychosocial impact, pandemic on children and adolescents. As doctors who are caring, we have to advocate for better understanding at large the society of their needs. Summarize a few takes for gynecologists and for health in general. First, the fact that these that I describe are universal, applicable, that essence, development and rights is our task of professionals. And I would encourage my colleague from India to train their colleagues in these specific aspects in health. As I mentioned, we have worked with patients. It is also something we do program that my colleague very well knows, and which that is easily accessible, is providing a training course in adolescent health and medicine the world. So I thank you for and best wishes for the future of FOGSI.
Thank you so much for giving us an insight our adolescent patients in the current era. I would request Dr. Alpesh to hand over the oration plate to Dr. Have the oration plate, please.
It's much. I'm really moved. Word.
Yes, sir. The pleasure is Dr. Alpesh, sir.
I cannot get this like
shared on the slide.
Somehow I am getting problem.
No problem. We can
Dr. Meera Agnihotri, Dr. Ragini Agrawal, please.
Dr. Ragini, ma'am, please unmute yourself.
Meera madam is there.
Yes.
Ask her.
Dr. Meera Agnihotri, ma'am, to please.
About the.
I can't see it actually.
Okay.
So it will come to
Perhaps
me.
the font is.
It is too small.
This oration is awarded to Andre on August in the FOGSI's International Health Conference. Exemplary work in the field of. Want to add anything, madam?
Really congratulate the Ure for his wonderful presentation and the way he development of the brain, devices, emotional manifestation, and the behavior of the adolescent. It goes beyond, you see, talks miles about the subject, whatnot. We obstetricians, we doctors, we pediatricians sometimes look only for the one aspect, but narrated that we must the transition phase of the developed girl who has emotionally taken the story which he has told, then he has concluded maybe that then, but at the same time she must can you see come over the redone. Done cannot be undone. But, she must not take steps that it is going to undo these things here. That these girls must be fully to understand what is the emergency contraception. These things, they must be in close with the obstetrician or the person whom the way he has told one by one, maybe that she was waiting for to open her emotions, but are going just to hush up and just discard her. So once we her that we are able to correct path, and that is how we get very many emotional crises. Girls like suicide, other things, depression, and so on. I really appreciate the way you have very academic, analytical, without saying that everything is precisely by the audience present over, think over like anything for on. Thank you very much once again.
Thank you so much. Last word for from Alpesh before winding up.
Thank you very much, Dr. Pei. Wonderful oration, a great oration. You have nicely presented the effects of COVID-19. Say in a single line that give us a new direction for adolescent health. Thank you very much, and we congratulate you. Thank you very much.
Over to you, Yukti.
Yeah, thank you. So moving on to session. Neeraj, can we have the media wall?
Thank you very much.
Thank
Honored
you so much, sir.
and have next.
Yes, sir. Right. Neera, we are moving on to the next session, please. You're supposed to play the video. I would like to persons for this session. Dr. Ma'am is a professor and head of gynae and consultant endocrinologist at Bombay Hospital Institute of Sciences, Mumbai. She is also editor-in-chief of Journal of FOGSI from 2018 to 21. Welcome you, ma'am. The next chairperson, Aurora. Is the president, Gurugram Obs-Gynae Society. She's been a senior gynecologist in private for the past 30 years. She's a director at Gurugram. Next, Dr. Vibha Dua. Ma'am is obstetrician and gynecologist and Dua Hospital, Sonipat. I have a sincere request
She is
to
a
the
senior agent of her OBGYN.
Yes, ma'am. We welcome you, ma'am. Sincerely request the next speakers to as we are running late already. Request Dr. Suvarna Khadilkar ma'am to and introduce our next speaker, Deep Roth, who will be speaking on and adolescent health. Is there? Over to you, Dr. Suvarna.
Thank you so much. It's a pleasure to be here in this session and very well organized international conference on health. I congratulate Dr. Ragini and the entire for working so hard and putting. After having heard from the professor, let's move on to the next session. Interesting title, that is new and adolescent health. It's a very novel topic, so I think it's going to be a treat to all the viewers. Let me introduce the speaker, Dr. Who has connected from all the way from Singapore. He's a pediatrician and neonate in private sector in Singapore. He has taken his Maharashtra, and he and super specialty training Singapore KKWC, published few articles and present local conferences, and he has been part of training education projects. So we are all listen to you, Dr. Raut, neonatology and adolescent health.
Namaskar. Good evening to everyone. With this opportunity to share on this platform, I really thank and all the esteemed speakers. Special word of thanks to my friend Dr. It motivated, inspired me on this topic because he is always concerned about adult health, adolescent. Extremely good work in Maharashtra. I can share a little bit on this in my mind. Let's start with few things. Okay, let me share. Okay, so neonatology. This is about me. Couple of self-declaration, no commercial competing interests, no financial data and pictures are taken from open source, no copyright claims, and if you use it or reuse it, do in a history and evolution, something which started long back in ancient scriptures and all that. Modern science is from the Rome. Later, first thing it was practiced by obstetrician. I think it's quite natural and normal for obstetrician to deliver a baby crying. They would secondary go to the research and they will continue to look after. That was happening previously. It was first time in 1916 neonatal term was coined, and 1975 the application happened in the USA. Change in neonatology in last 25 years. Wide reach. It's a decentralization from few main district place to now a smaller parts of the a basic neonatology services can coverage. Previously, it was only located or supposed to care and low birth weight. The horizon had cases to be accepted in facility. Wider acceptance, confidence in the obstetrician. There's a bit more confidence in other specialties to say that baby will survive. There was a time say less than 1 kg baby may not survive. Relatives and to advise parents and let the baby go natural way. Confidence has gone up. Now people say, no, you must try. They have a fair chance. Confidence overall in the society as wider affordability, afford a little bit better in care of the patient. Cooperation and collaboration with different doctors, as well as specialties and a paramedical staff or occupational therapy, physiotherapy coming together to look after. Change in last 25 years. Advances. There had been a mechanical ventilation. We learned a little bit neonatal ventilation. We are able to more gently, more naturally. When you offer a better quality of care, outcomes are going to be better. Drugs available, the main then INO, the suffer in saving the lives of babies. For hypoxic pathy, the cooling, the hypothermia had given, and in the third world country, limited resource country places where this has been there's integrated monitoring, there are monitoring which puts data together to give understanding of the baby at given point in time, better decision making, better care. Parental nutrition, previously feeding of the milk was the only nutrition they could have. And electrolyte was not grow the baby. But invent of parental, the reach of parental nutrition to most of the packed and parental nutrition as possible for us to care for the babies at different point in time. Equipments and more interest in commercially to which are specific for neonatology help us to monitor and care for the baby. The things that moved from laboratory, from bench to bedside, the X-ray, other monitoring moved to bedside that to care much better way. In the ECMO, extracorporeal membrane oxygenation, we are able to save the lives where say that the futility of, we are seeing a good results of it. Better use of artificial intelligence, more data is put together to and better understanding of patient. So we had moved from left to right. We started with simple incubator and simple. We are now jungle of equipments and all geared up a new age technology gives a better care to the patient, better outcome. Now age of viability from 28 weeks to 22 weeks. 1 kg was a denominator to be worried about. 90. Now it has become 500. Able to care. The hypoxic issue, HIE outcomes had improved. Complex congenital heart conditions, we are able to provide better care. Confident, they are able to do better surgery. That made them unable to have a better hang of the conditions and operate on critical surgical condition, esophageal annulus. I remember during my early days, esophageal atresia used to be a condition because now the outcome of esophageal fistula is much better. There's a let's go ahead and do it. Metabolic condition, there is early identification, there's a treatment, there's better reduction in the morbidity and mortality from the. So overall, there's improved survival on better care. In terms of the neurocognitive and neuro, we'll see a little bit more on this. Most common causes still at this point in mission are low birth weight, neonatal HIE, hypoglycemia, hematological condition, complex congenital surgical condition, syndromes, issues like transient difficulties. Survivors overall carry a little high neurocognitive impairment, developmental and visual impairment, cerebral palsy, emotional problems. These are seems to be a crux of the preterm contribution to date is still up. There are more than 15 million births 2020 which contribute 50% in 6 countries of India, Pakistan, Indonesia, and US. Resource poor countries, third world countries, a lot to preterm birth. The survival had changed. You can see 3 to 2000s has gone up to simply chart See, 80s, 90s, early 200, you can see that 20 weaker, it has gone up nicely. Later, this is overall, not only one state, one country data overall. But what it implies that they would go on at some point, adolescent and adults, and they become and they come with their set of own issues. They have a higher the incidence of asthma, cerebral palsy, mood disorders, more to come. What is first time was described famous epidemiologist with Barker in 1980. The intrauterine growth retardation has relationship, a cause in coronary heart and non-insulin. Although this was found to be study that point in time, not been substantiated in other world, especially in low-income countries. The hypothesis remains the main source of that happens from neonatal to adolescent. It's developmental origin of health and disease hypothesis or adult diseases. Pregnancy does influence the life. Growth retardation in the pregnancy, small baby, when the small baby nutrition that leads to obesity, because your genes, epigenetic causes to optimize the energy you get in terms of nutrient time, and that continues to operate out and you get better nutrition. Readaptability study, and that is what he proposed, that 50 gene hypothesis, but been substantiated in a lot of studies in a low resource countries. I think this works in a different way. So overall, if you see the incidence of adult onset diseases tends to be more on the either side, from the LGF both sides. So having a norm gives you optimal and maximal chance better adulthood as compared to and a large birth weight. So extremes need to be avoided. Organ specific, the babies, they are known to have a smaller the there is less of volume. Sorry, there is, sorry, moved back. Apology. I was talking on the. Sorry. So organ specific, small brain volume imaging had suggested there is in the brain, which is especially in prefrontal cortex, and deep results in overall decreased eye functions. But these results are the studies and report. It may be different outcome measures, different evaluations, and the plasticity of human age in different environment may affect in different parts of world. The mental health wise, observation of higher frequency of school behavior problems when childhood to adolescent, they have a issue, they find it difficult to make relationships. Likelihood of being diagnosed at spectrum, despite they do not fit, but some of the personality traits prone to be diagnosed as autistic. There's a fourfold higher risk of anxiety and time. The different person, they are known to and shown to be a bit of, which is good, little shy, less substance abuse, the least tricking, and that little prone for interpersonal relationship, break the ice so easily and so fast. Their approach, the risk of and bullying is more, especially for and NGA babies. There is known documentation that systolic and diastolic readings can be high centimeter at any given point in time. Possible postulation of endothelial markers from the time of low birth weight. There's higher risk of the hazard ratio of 1.6, 5-6 times more risk of the heart issues. There are metabolic issues with deposition of fat, dyslipidemia, higher risk of asthma, abnormal, which is decreased. If you can see on, there is a decreased FEV volume is low, irrespective of BPD or no BPD. That means bronchodysplasia or no dysplasia, known as chronic lung. There are better pulmonary outcomes in the stage. This is where the surfactant came, strategies changed, there is advancement in the ventilation. There are few things to be known. These lungs are still normal, or they have influence of smoking, pollution, age related, and interaction with the medicine to be seen. Metabolic and renal, insulin resistance, low insulin. They are out of range values for lipid profile. They are out of range and make the abnormal yet, but for given the reference range, whether they will really make time to be seen. They are also known 85th centile. Renal wise, there is here to be seen urine plasma creatinine marker of renal function is also. The true magnitude of renal effects are, there are not many studies who get it. They are not major out published on this. So things to be seen. Neonatal HIE, pre-therapeutic hypothermia, higher morbidity. After the hypothermia trials and result, it has become a standard of care for HIE. Moderate. Two big trials from US and a total body cooling trial. Good outcome. The reduction in mortality by half. They had published the for this kind of survivors, seen that there is a less better in terms of the control and hypothermia. They are still at of non-HIE studies, and that data is yet to be available. Now, with the advancement of hypothermia, new trials and new age outcomes, we need to redefine the goalpost. Go from there. It's important to at risk of neurocognitive and renewable behavior at any given point in time with any. It's always good to prevent the HIE. Neck, which happens 9% in the low birth weight. Long-term outcome, there had been varied results, but generally would put it that they have a little 50% chance of neurodevelopmental delays. There have been a lot of studies on outcome of born preterm. Review had like 126 systematic reviews and 114 looked at 22 to 34 weeks of gestation, and their generally what they had noticed, there are more neurophysiological behavior problems, disorder, metabolic syndrome, early age than the term. Otherwise, at 50 or age of 50, you 40. It's a as the life is continuum, and birth weight, birth history would help. So what do we know? So now we know it made some information. Now we need to move from let's have a bit of wisdom on it with it. It's a circle of life. Early, what happens around you? You at some point in time, that means environmental factor, pregnancy health, the preterm birth, societal influences, the care, and then you become an adolescent, you become, and you contribute back to society. Circle of life we are going to see. Be aware. You're looking after the adolescent, been there in a NIC, had an X prematurity low birth weight. As an obstetrician and a gynecologist, you would need to be aware. In this X premature baby, check the weight and gestation at birth. Wait for normal age at that point in time. For them, if they're born very small, the obesity for them, they're more prone and metabolic derangement. So to screen their bloods, understand they are at higher risk of dysregulation, which a lot of times their menses, either in area or would have some impact to look after. Height wise, they are known to have a bit of a short. There is increasing use of growth in achieving a, and how it would interact in terms of the rapid weight, whether it will see and they will make them more prone for kyphosis. These are the things. Since the numbers, but there's some observation and expert published here and there, which because at some point, pediatrician office to or gynecologist office or adult physician, we don't get to see that part of them or their development. There are also a lot of body image issues. Share with anyone of pediatrician. Easy to share with obstetrician or gynecologist. Systemic. Vascular, there are higher risk of blood pressure. There are some hormonal coagulant medication may carry additional on top of what they already have. So when you're treating these patients with high risk medication, be aware they may have a different effect. Regular patient, regular screening, these side effects. Then there are a lot of complex conditions which are surviving in adults. So you may be to be aware with additive prophylaxis. There is an update on 2000 review. Be aware of this patient because some of them are on long-term medication.
Dr. Raut, I'm sorry to interrupt. You just have 2 more minutes to go.
Go ahead.
Right. Thank you, sir.
Then the cognitive and mental, they may affect the ability to express. So be careful when you're taking. Everything that they say may not be reliable. There may be a loss of memory or a loss of painful events. They may not be aware of details of early treatment or what they had gone through, what therapies they had taken. So it's always a caregiver in the discussion. Always provide if you're given a treatment plan and other experts if you in terms of the mental abilities. Other system-wise, higher risk of renal medicines, some TP liver functions, so there may be some parameters. So just be aware when you're for them. Then quality, the quality of life is different, and for them, life is different. So parents poorly for the global in general overall behavior. But if you ask teenagers themselves, score themselves close to a subjective quality life perception is different teenagers. So the teenagers own quality of life does matter. And what do we contribute as a medical professional? We contribute negatively. There was a survey published which showed that doctors significantly the survival rate and overestimated the rate at that point in time. Nurses and nurse practitioners at that rate, but over the period, long-term various studies and reports had changed the guidelines and we had changed our view. Still not there yet. Time to tell us that we should with our opinion. So from there, we had moved to a better outcome. We are looking at the better intervention, which is intervention. And with early intervention, change in a perception of quality as well as the children. I think is the right step in a right point in time. But cost. In USA, insured population study had shown the premature of billions. A 24 or more at birth, his hospital care would cost $1 million to $1 million in lifetime. A lot of money in terms of care. But or is it an investment? Is another perspective. We look at the time point, exciting time for us to really, as it mentioned in one of the reviews, holds the infant collaborative study, which look after up to 3 to 4 preterm babies, and she thinks it's intervene and we can do a better healthcare. We understand the movement of one sector to another, and we collaborate, and then we move forward. If we can, over the period, make a gene for us to know people who were born small, they were born premature, like Newton, Albert Einstein, Winston, not Bonaparte, and there are few Olympic gold medalists who are born. So if you can get one of those who come up to baby, you think it's expensive? No, it's the investment in a human life. The resource is the best resource on planet Earth. Let's put all our effort together, the best possible care, so that a good human being can contribute back to society. That's all for me. Thank you.
Thank you so much, Dr. It was really a great talk. Now, Dr. Vibha Dua, ma'am, the very dynamic.
It's really a privilege, this e-conference. Thank you, Dr. Chandan, for including. And it's a great privilege to introduce who needs no introduction. Pioneer in obs and gynae. She is working as IVF infertility specialist in Research Center, Mumbai. She is Gynaeward, the Center for Women's Health. She is currently the founder president of PCOS Society, a multidisciplinary society which focuses on the subject of PCOS. Ma'am has by the name So Shy to, which is available on Play Stores and what adolescent children. She chairs the interest group on reproductive endocrinology and also the international advisor special interest group safety and quality. Madam, I feel highly obliged to invite you session and to talk about evolution. Thank you so much. Dr. Professor Duru.
Thank you very much me for this very session, and I'm very happy to be here. To be talking to you about recent revolution. Something which I'm very happy to talk about, and I thank the organizer for giving me this opportunity to discuss very interesting subject. When we talk about revolution, it is different in different dictionaries, but the message is revolution is a collection of or social to change because we want something else to change. Different kinds of revolutions. The revolutions, just like were done by Mahatma Gandhi, by Martin Luther King, Mandela, for the sake of the country. And there have been violent revolutions, the Egyptian revolution in Cold War. This has been very great revolutions or revolutions which have country, and that is our lively agricultural revolution, the industrial revolution, and the information revolution. Agricultural revolution changed the
had to find or grow food for themselves. From the use of complex irrigation systems, surplus foods changed their way. The Industrial Revolution, which were made first by hand, then newer technologies. In short, machines replaced and labor. The invention by which the invention of little computers, rapid communication together on a fingertip. Just like the whole world is here on the screen. Globalization with reshaping of and economical growth. The adolescent revolution is involves adolescents today age when there's a of digital media going on at that age in life. What today? So before we go to, let's go back 150 years ago. Talking about Dr. Anandibai Joshi, woman Indian doctor, who was born in Pune in 1965, and child for her because mothers those days, their girls learn to tolerate the kind of attacks they would get, and therefore she punished her with stick live charcoal. As tradition, was married at the age of 9 years to a 15 years her senior, and she had 12 years through a very complicated delivery in 10 days and could never conceive. This was the story of the childhood by Joshi, who was our first woman. During this period, the women's reform movement, and it started becoming a status caste when women started getting, and her husband actually considered in that class and therefore educated, though she was not keen. Chairs at her, he hit her, he threatened her. She was still a child. This affected both physically and mentally the story of her adolescence. So women who were ill and refused to be doctors, she decided to become a doctor. US with the help of a very, and here she trained for 3 years, and due to cultural belief she ate food, wore a sari even in COVID, and refused to take Western medicine. Until she became very ill and in the prime of her youth, 2 years. You can see her, the way the Mr. and Mrs. Carpenter maintained her presence in that where she lived, and was not able to achieve her dream of training, which she wanted to do after. But while she was in the US, a letter to her husband, a Hindu right to utter a word. Husband, I was born to but on the contrary, I have the to allow my husband to do what he will. Quiet. In short, she said actually to decide whether she's to do what he wants or to keep. So in short, even at that time, about rights of women. These were the rights of young adolescents of the past, only about 150. So let's switch from 98 to 2020. Today, adolescents are increasing in number. 10 people globally are under 5 years. Globally, the graph are declining. There are less number of children, less number of adolescents. In Africa, you find that it is still. Access to the internet is a factor in which populations are and ensuring economic growth. Whilst in India, with the use which is rising very, very high, year by year going up, and we will be able to ensure and prosperity for our they about the world around them. So media, and I'm talking about adolescents all over the world. They are using campaigns to raise awareness about this. They are taking matters into their own, fighting for their cause. There are many girls who have fought for various rights. I'll talk about Nirbhaya. trying to save herself, who was responsible for the Nirbhaya Act into place. It was which caused such a social outburst in Delhi and of course all over India. Nirbhaya Act came into place. Very strict regulations for sexual. Then you look at right to education for the story of Malala Yousafzai, who fought for the right of education for 2011. She was awarded Pakistan Youth Peace Prize. She started because she got national recognition, decided to kill her because of fighting for her right to education. She went to school and she was shot and in her arm and neck. Sent to UK. She went to her parents for treatment, and there she received time and she received the prize at the young age of 17 years. A prominent activist and always fights for the rights for education very globally. So what Malala is a day celebrated in her honor. It's a day of every boy and every girl who have raised for their rights. So adolescents voices. In Sweden, Greta strike for climate change. She says, we are children. Why should our future when no one else is caring? Every Friday she goes and sits at the secretariat, Mantralaya as you call it in Sweden, invited at and speaking at every, including the World Economic Forum House of Parliament. She was only when she started it. In India, Lakshmi, 29 years, was attacked at the age of by a man who she refused, and her face, and she has been advocating through a petition to taking the cause to the Indian Supreme Court. She won it, and now today will easily off the counter. Acid attack survivor, she speaks on the newsreader today. Similarly, India has 250 adolescents, more than in any other country. We have the most powerful behind us, and we need to give them full to become very productive. Menstruation and sex are taboo. The process has begun with more adolescents familiar with. During this period, we need to talk safe sex, reproductive tract infections, unwanted pregnancies, unsafe abortion, chronic diseases it can cause, death. We know that Indians are also sexually active, though if you talk to parents, they accept it, but there is always % of them by the age of 16 active. And therefore, reproductive should be offered to these young people. They are aware of what is going to the outcome, what you say, sex. 15% of adults, 6% of unmarried adolescent girls in the most populous states of India. There's a steady increase in teenage pregnancy, early marriage, and low contraceptive reasons behind this trend. Because in adolescents, almost 26% before the age of 18 years, 12 women aged 15 to 19 years others, and 1/3 of India's of adolescent pregnancies. A lot of adolescent marriages taking. It is against the law. It's against the law to get married before the age, but it still continues. So by set of childbearing, India could projected population of 1 billion by almost 25% by 2050. So we just use this system of delaying the onset of childbirth to be able to reduce our population by 2050. The forum of FOGSI over a period of 2001 to 2010, strong FOGSI trainers, 8 million youth on topics related to hygiene. Now this we are talking of something 20 years ago we started. And we time on puberty, menstrual hygiene, contraceptive and sexual health. We trained by WHO and Mauli, who today was our guest of honor, trainer for us when we did the 5 Mumbai. And these master trainers and thousands were trained, and we went both urban and rural nationally, talked to a lot of young. There were many people telling us that, oh, will the schools accept it? No, the schools welcomed it. This adolescent education program was as a national program in 2000 time by the government of India, because it happened and we trained so many young children or teenagers, not children. The program in and we offered preventive promotive services. Within 2 years, the AEP was banned and as parents objected to the illustration such as intercourse, condoms, and masturbation. Unfortunately, it would strike, it would corrupt our young, decrease the virginity age, and it would. But in the rest of the state, it was more of a political move. It continues to be in the rest of the states curriculum, but teachers are not prepared to teach, and it is left to the children what really. So if your parents are shy to talk to them, and the internet section, they go all kinds of websites, and therefore through my NGO, we are too shy to ask. And young information from it. The app is currently in regional languages, available on Android for all. It's interactive, answers all. We have added a parent's corner to it. Really informative, and I recommend your young teenagers. We also initiated youth-friendly services in the city, which we ran as a Kishori program through FOGSI in collaboration with ICDS and the local hospital doctors. Now we know also creating a lot of awareness in adolescent reproductive sexual health, making films like this film which was on Padman, which using napkins, sanitary napkins, sanitation in rural areas. Eliza Burton produced a 26-minute film in India on menstrual hygiene. The film period, she award for this, and in her acceptance speech, period should end a sentence. Because it has been found girls start getting period. If you see this, as soon as the girls reach secondary to the 17% of girls drop because they do not have 2 million girls. They do not have enough for sanitation. There's a go to school, there's a lack of opportunity access to gain economic independence. In India, if we add over with GDP by 2025, included in the economic development, include 50% of our population and women into our labor force to an economic development, we increase our GDP. Today, according to the agenda of the Indian government, opportunities to women and child and promoting sanitation. UN Secretary General Ban Ki-moon, adolescent health is not thought of to sustainable development and back. Adolescents are being left. So as a global community, we have actually trying to address childhood, and more recently, we are focusing on the health of older adults. Adolescence has been completely neglected. Something we need to address because we have a number of young people developing diseases, and this is all happening. Lifestyle changes which are obesity. There's an increase in NCDs because there is an environment we are dealing with. Far cheaper, but they are unhealthy. Policies are reducing physical spaces where children and young people. So our health systems need to start what we are saying and what we are asking for. Victoria Tonin has mentioned in the Lancet, says we are tired of being stereotyped, experienced, and we instead, and adolescents are activated and ready to take matters into. We are concerned with equity and we have a vested interest in seeing it should happen because it affects our. In this digital age where information, they have greater connectivity, share similar challenges with all around the world. They are demanding taking responsibility for seeing it. That means we should have meaningful partners as adults, sit next to them, have to say, and listen to their decisions. If we want to promote health for you, very simple solution, but it is. We should want our health system to promote health for young people, included in the planning, in the design of policy and practice. It is the ministry makes guidelines for experts. We need to invest into it so that they can make policies. So now let's see how the digital has affected the adolescent evolution. The digital revolution has had a tremendous effect on their education, entertainment, and social behavior. Adolescents of today learn, play, and interact more in the past 15 years. 570 years introduction of the printing press. It took more than 50 million to take, the amount of time it takes technology to be used by 50 million. For radio, it took 38 years. For television, 13 years. The 4 years. Facebook, 3.6 years. iPads, 2 years and 8 days. So Google has grown. And today, many of us speak about the brain evolution and neurobiology. We must understand that the adolescent brain is a defective adult brain. It is physically forged by the forces of evolution. Different features compared with children. The three most robust adolescent stages are: they take increased risk-taking, sensation seeking, and a move toward greater peer affinity. So this is something which is a highly of the brain of the adolescent, because it is actually a lifelong process to the environment, and but at the same time it earliest, it is most robust in its development, and compared with others have a protracted period of parent, and it gives the advantage of protracted. So we need to make sure that the constantly sensitized, motivated. We must remember that as the teenager grows, sure, by growing larger, the brain is getting more specialized. The total matter volume peaks at about 11 years and at age 13 years in boys. We need to encourage questions rather than telling them keep quiet. Areas such as the prefrontal is a key component of neural circuitry, and it is involved in judgment, impulse, range planning, and it continues changes well into the 20s. Cortical matter is the matter which helps, and is the reward circuitry and changes around the. And that's why around brain activity increases through myelin in the nerves, but myelin decreases. So we have to see to it information, so much exposure when the adolescent brain has been adaptation to the environment. So the digital revolution is all to learn about the world, to establish, to socialize with their peers, not have access to this medium. Children who are from the low socioeconomic may not have the facility for this relation, and that's why a lot of contradiction, whether in urban India or rural India, difference whether she has an equal or not. The SDG index is an index supported by the Bill and Melinda Gates Foundation. 14 of the 17 MDGs such as poverty, health, etc. And unfortunately, indicator has a score, and India is pretty low down on the score. 0.4 billion girls score, and no country has excellent score or above. India stands, no country has women or girls equal to men and boys. Countries do better. We are 90 among the 129. So here we have situation of digital revolution is very, very fast with internet, blockchain, robotics, and manufacturing. So in sharing the young in our country and support in skill-based training. And if you see the Make in India thing, to see that India has been, for doing business, the index has gone shot up 30 places for foreign investment. 82 metro trains were made of Sydney. And that is when we feel Indian things are available abroad. So now genie out and everybody feels medium, it will take over jobs without any jobs. So, but unfortunately, medium that could be negative in seen that we worry that there'll be more violence, there'll be multitasking leading to analytic thinking, there'll be non-productive time, but there are many positive educational opportunities through it, expanding social interactions and more information. So the revolution is being brought in by the young in the revolution. They want a world they live in, they want their rights, they want to be involved in. And Shirley Jackson, who's the Rensselaer Institute, world's challenges will require the brain power. Enough of the talent pool is just silly. We need to get women into it, and my presidential year, which was focused, and that's when we made the tagline, let's make the majority. Thank you very much for your time, and I will be to again thank everybody for the opportunity to talk about this revolution.
Ma'am, it's always a pleasure hearing you.
Thank you.
Now, may I request Dr. Kiran Arora?
Nisha, for your very informative discussion on adolescent digital revolution, impetus to this revolution. Adolescents are no doubt the nation, so we really need a patient hearing, care for them today, so that our future tomorrow. We really to their unlimited energy rather than snubbing them for their questions. You've really put in all the points. I thank Dr. Raut also for lecture on adolescent of problems from the neonatal period. So very much, many points from his talk also. Thank you. Really had a wonderful session. Thank you.
Thank you very much. Thank you.
Dr. Kiran Arora and all the other. Let's start with the next session. Two of the very esteemed international speakers. I invite our chairperson, Dr. Madhuri Patel, Nisha Kapoor, and Dr. So our first chairperson is Dr. Ma'am is the Deputy Secretary. She's the Treasurer FOGSI to 2018, and she's the Secretary FOGSI in 2009. Next chairperson is Dr. Nisha Kapoor. Ma'am is the President of Gynae Society. She's also Haryana Association of Gynae, and she's the Vice President of Haryana of registered obstetricians and gynecologists, and many more accolades to her name. We welcome you, ma'am. Our next Dr. Saroj Kumar. Ma'am is Swastik Maternity Center, Gurugram, of Harabgyn Society, of Gurugram Menopause Society. Welcome you, ma'am. Dr. Madhuri Patel, ma'am, and introduce our speaker, Dr. Al-Rabi.
Dr. Yukti, for your kind words. Start our fourth session conference, which is going extremely. For that, I congratulate Dr. Rajesh Gandhi and their team work. Now we have a first. Can you display the introduction? First speaker? Yeah. We have Dr. Jamila Al Raiba, WHO. She's a regional child and adolescent health at WHO Mediterranean region and sectors in adolescent girls in African region. She is going to on high risk behavior in Asia amongst adolescents. Please, I invite you on the talk.
She has to unmute.
Now?
Yes. Hi.
Namaste, everyone. It's a pleasure to be joining such panelists and participants in the conference. And 2 days, I was following the participation of health, and I'm really proud of strong adolescents' participation in this conference for the topic. Dr. Shandan, and for organizing this opportunity to me. Share with you about adolescents in the Mediterranean region, also to give you an overview of sexual and reproductive health in the Mediterranean region with focus on child marriage, opportunities, and challenges. When we talk about, I think the COVID-19 comes, and in our region, countries of the region have and the total cases is around 1,000,000 with a total around 49,000. Another challenge we have in the region COVID-19 is the emergency. We have 4 acute emergency: Somalia, Iraq, and Syria, and we of countries with grade with protracted emergency. The emergency, we have around more than 15 million refugees and around 18 of internally displaced. And this also more community population for the need and assistance. And in mind that 48% of these population in need for assistance are below the age. Mortality among region, we are having 15 per 100,000, and this is the second globally after region with high adolescent mortality rate. Of death among our adolescents, among the youngest adolescents, either males or females, is killing, and the other 5 causes ranging from for injuries and communicable disease. We see that collective violence and legal road injuries, congenital respiratory infection closes among the females. Older males, still the war is the first cause of death by the road injuries, violence, drowning, and self-harm. For adolescent girls from 15, still number one is the war, and the second cause is the maternal condition coming from the child marriage. And as we see next in the about the data around this, injuries, tuberculosis, and the mental issues is coming more. Compare this in the countries in the region. The picture there is number one killing is road injuries, mostly is with issues, self-harm, interpersonal, congenital anomalies, and leukemia, non-communicable diseases in countries. If we come to the mortalities, is still number one morbidity among adolescent girls and boys is the second cause is the iron deficiency. And this is among the countries and also as well countries. And from your presentation, we heard that issue in India as more of the countries of the world. For overview and sexual reproductive health rights, and as Dr. Shand talked about the progress since the International Conference for Population Development 1994 in Cairo, in the region, the 41 million adolescents, 94, and also those adolescents has diverse in and living in different contexts. The region is characterized by very big diversity between the countries. There is a significant shift of the burden. Have double or triple burden health, ranging from diseases, communicable diseases, reproductive health, and also in violence excess. Significant progress made has seen in many countries, and the adolescent girls today are likely to marry late, first childbirth, use and less exposed to female mutilation in portion of adolescents who are overweight or obese, especially in income countries, but we can see in low and mid. The adolescent fertility rate, but it is a big variant from 0.1 thousand girls in Lebanon, 57 in Syria. As we see, unequal progress between and countries in as in the situation of lives has been worsened. It's in the emergency and refugee countries where the girls are vulnerable more to abuse and violence, also are more exposed to substance, smoking, injury, violence, including gender-based violence. Also the increased social media use. They talk about this, and we find there is a huge gap, the urban and and the also poor and rich. This has really become more during the COVID for the or online learning. There is emerging trends in the and that need on it, and there is increase of ovarian and breast cancer in girls. And as you see in the region has increasing of these and in the top of other regions in the world. Child marriage and the level as we said, there is a decrease in areas. And I'll give you two examples of the levels and trends in Iraq and Yemen. If you see Iraq, 2006, 17% of the girls married by the 18, and in 29 period is during the conflict, has been increased to 28. In Yemen, which has a conflict, but the conflict is 15, and before the conflict, it is 1991 reaching 50%, and it decreased to percent in 2018. But the war started in 20, and I'll share some on how this affects marriage. In the 28% of girls before the age of 18 and before the age of 15. During the war, terrorist groups selected girls and women as a spoil to be raped, sold, or marriage. And this has happened in Iraq and Syria. Forced marriage and child marriage, a growing problem, mainly displaced population and refugees in Iraq and Syria. The outcome, as we said, this where our adolescent, the girls are living in. For Syria, the child marriage is as high as 40% among in Lebanon. And on the same time, increase of child marriage is in Lebanon. And this gives us that we have to focus on context. But there is a big burden on communities in many countries, conflict area. Also, there is increase of registration, which almost tripled from 12 to 32% during the conflict. The largest humanitarian crisis, and in the last 5 conflict, really bring of Yemeni to suffer constant threat lives with the looming disease outbreak in the top of COVID-19. December 2019, 4 million people are in for humanitarian assistance, 30 million, the total population. So it's a huge need. Let's remember that around our children below the age of. The child marriage has increased in over 65% of are married off before 18 compared to 50% before. Really to share some of the, the child, and there is a FOGSI program, and it was presented Yemeni girl in some areas of emergency, and the girls she met, she is from Syria, but she got married when she was old, and she had 4 children. She said, I didn't know all these responsibilities. I killed my baby, I fed her things I shouldn't have. I would put sugar in her milk, was a newborn, and then medicine when she didn't need it. She would cry and I didn't know. And also she is 20 and I am having a nervous breakdown. Now when my children have to leave them with my sister out of the house. And this when we overwhelm our young responsibilities, mostly child marriage, only abuse and domestic violence. Also the responsibilities are huge for a young girls. A child from And this is really was the documentary, and it shows selling of girls for marriage. Mut'a marriage is a short. It is not registered. And, they prefer this marriage because there is no, and they can have the sex and they run away without any commitment for them. Just 14, and she wanted to have a mut'a marriage through a poker to an older man home from school. 9 years older, Muna is under family to marry and is fight for her future husband out. She is no longer a virgin. Is an issue that really most in the region have suffered, and they have been killed because what they call it the virginity. It says that her uncle killed her cousin for having a boyfriend, and she attempted and thinking suicide. Child marriage is not being adequately addressed in humanitarian. And it is the UN, United Nations should be really one of the focus. Nationally representative data, conflict areas such as Syria and Yemen, the child marriage rate and might be estimated with the numbers that we shared. So now the child marriage has been by pokers and results in a girl into sexual slavery and tourist marriage, especially displaced population and among refugee community. Necessary system for data collection, complete and accurate civil registration statistics system, and many marriage because they give the wrong age of this for registering marriages. So we have opportunities. Talked about the SDGs and the human commitment of the countries. A good entry point for more advanced adolescent health needs is including reproductive health. Legislation, it is an opportunity, but not always. Bearing in mind, for example, Syria, a minimum age of marriage, but it is not enforced. And from NGOs to enforce those, implement. There are regional tools, for example, an adolescent health in humanitarian guide. There is a framework, SDGs, adolescent is included. Also resolution from minister to implement. But we have a really commitments and high policy from reality and from to really actions, resources, and this is what we are trying. Another opportunity, the US regional services adolescent health is included, focus on sexual and reproductive health. Also, provision of comprehensive sexual has been in the region countries to introduce it. Media, including the social media, advocate and reach more adolescents. Really, this is through what we learned more and more by using the adolescents themselves and to advance issues. Holders at different level. We have at a regional and mainly at country level. NGOs runs by also young happy to work and they significant efforts at a country research and WHO at the global level and support how we can and guide is in caring for in prevention and caring for adolescent girls. And this is run by Chandra at headquarters, and we hope very soon. Documentation of best practice, creative approaches, Also on use of technology in collecting the adolescents and reaching also adult providers and social providers. Also multiple positive impact of investing in adolescents as delaying child marriage. Will give ease of risky pregnancy, sexually transmitted illness, is for the complication, obstetric fistula, and opportunities for young people to educate, to take their themselves.
Excuse me, ma'am. I'm sorry to
Yes.
interrupt. Left.
It will be. Pleasure.
Thank you so much. Thank you so much.
You're most welcome. So in the region, we have a large group. We have a good progress in ICT region, yet inequality. Substantial progress in certain need to build on best practice, more to ensure all adolescents have for their own free and informed their needs to be met, also on emergency and humanitarian. I would really like to thank Dr. Chandra Molly, Elsie, and Matilda for this presentation, also for the resources from UNFPA and UNICEF. Thank you.
Dr. Jamil, very excellent delivery. Told us you have analyzed into insight, and you really problems of the adolescent. There are multiple problems in adolescent. They don't have access to adolescent center, and that is creating heart-touching incidents which should give us. One a girl, she had 4 kids and she was refusing to children, and the second Mona, she had motor marriage. So we are really disheartening to know this. We are giving you all this to all these girls, and we are doing work. So I really congratulate and about the insight of this adolescent problem very much.
Indeed, ma'am. Jamila. Now I Roj Kumar, ma'am, to please speaker, Dr. Galina Lesko. Yes, Dr. Saroj Kumar, ma'am.
The slide is not visible.
It's visible now. You can read it.
Visible.
Ma'am,
again try it, please.
It's displayed. I can see it.
Mobile, ma'am.
Using a mobile, please rotate it.
Put it in the landscape mode.
Landscape mode, ma'am. Dr. Saroj Kumar, ma'am.
Hey, it's my introduce Dr. Galina. Is going to talk on need adolescent healthy center everywhere in the and she is head resource center in YHS Neovita, coordinator of health generation, and she is MD 2020 Republic of Moldova. Galina, and first of I would like to thanks to you all the you are here. Wonderful talk on adolescence. Welcome, ma'am.
Much distinguished chairs. It's great to be here, and I to participate in 2017 Congress of International Associations Health in India. With me, the best membership, beautiful country. For my colleague Chandan, who invited me, and who give this invitation. I hear with big today all talks, especially last one, possible to be touched by a big magnitude of sexual and reproductive, and from colleagues, it seems we at the global level have a lot to do. It's different problem in different parts, but when we look more, they can see what similar and many approach part of the world can be helpful for us. The way I learn from all of you experience, propose a little experience in Moldova with this. Maybe it will be very for you, and you will have some clarification questions. Remain open to in future to answer the way I will to share a screen. Oops. It's my the screen.
Yes, ma'am. Yes.
Great. I want to show you where it's. This is a very in red. You can see a very little country compare with big and beautiful. And in my presentation, I present a little bit where and example of my clinic, overview of development of youth-friendly in our country, and maybe how we adapted this half of year to COVID-19 pandemic. I put many time on general or theoretical. I will try to share more what can be more useful. Moldova. Here, it's between Ukraine and here it's Russia, Europe in established its former Union Republic. It's now an European country. Independence 9 years ago. Very small population, 500 million, and one of 5 person from 10 to 20, and around % of whole population are 10 to 19. It's much less than in India. And if to look at the health status of adolescent, we causes for mortality to avoidable causes, trauma, medication, suicide. Incidence, and it's one of the Europe region. Adolescent is one of the highest in region, and we have disorders, and it's at least 1/3 of young people, at least one form of abuse during the problem of abuse. Fortunately, conflict, but in family, it's quite in bullying. It's large, fortunately, and we have at least 1/3 of adolescents in last research that live with parents who work abroad. Have this problem that in near the 10% of adolescents without both parents who, and unfortunately comprehension it's not yet mandatory curriculum. And if to look at the new, what its name proposed themselves. It's one of the first in our country created by UNICEF initially as now it's a part of governmental system, and it's covered by insurance fund, state insurance fund. Have two main activity. One of them is to act as a youth-friendly clinic. One as a resource center in promoting health and youth-friendly health services in. And you see what have 18 these years. We measure it if it's possible to 18 years, and we move to 20,000 beneficiaries. Very big team, only 20 people. This is multidisciplinary team of colleagues. What it's provider itself. This is doctors, social workers, midwife, and also we have project and assistants because some project, and we doing consultation, we doing research, we doing activity, we coordinate our 40 health-friendly centers in our country. We organize this program for them. Funny facts, how created children was born during this, and also we offer already last years our state started to procure condoms and other contraceptive, and we offer free of charge through the and also through the family doctors. It's if to be sure our center, and you see what adolescents themselves when they write in context of children report on of the right of the child, highly appreciate this kind of what they, it's very big trust on such services, and we look at our network, our youth-friendly health services point in our system, not entry point with a very good system to easy access of health services. And you see what in our services are focused, have approach and are focused on priority problem. Half of them are to especially sexual and reproductive health of people, and health and the nutritional disorders. Violence here it's medical problem, and the gender care, but on psycho care in this case, and process of youth-friendly health need will stay very much in this slide, and could better, but we in 2003 we have pilot clinics our centers, and to develop small network of 12
hygiene and all those things. And all of you are so awesome with that, but just remember to kind of use moments to kind of as a fulcrum to do documents. Let's go on next, Nira. So then now let's go and then kind of mention it a little bit. Dr. Chavania from GSMC. So we know we are out there. So we kind of push it a little bit. So factors for STDs in adolescents, condoms, and matter. Like, why are we doing this? Why did last show, apart from the fact are in the States? Go ahead, Dr. Chavan.
Yeah. Thank you. I would like to, at the outset,
congratulate Dr. for brave, exercise, doing a conference which is a E, and it's amazing that the true leader, and she has done it. And this is the last day, and the last 3 days, India is vibrating with Dr. Ragi.
Dr. Chavan, let's turn. We said that we made a decision and thank everybody later on. Dr. Chavan, I'm
Yes.
sorry, sir.
So I understand the constraint, and with all the panelists and moderators, I would like to go ahead and the risk factors for STI adolescents. So you have to consider that the adolescent cervix, and there is lack of look, leads to dryness, can cause a traumatic intercourse living area with the risk of having STIs. Biological in nature. Well, there could be cognitive uses and the risk factors unable to have the or plan contraceptive like condoms, multiple sexual partners unable to STIs because they are quite old. Could be because of sexual activity, substance abuse, to the sexual abuse, or they are with an older partner, understand the relationship. Could be because of lack of sexual education, confidentiality. To the healthcare is also important things, which are these. So what is the efficacy of preventing STIs? Condoms are 98% effective in protecting against STIs, but more common chlamydia and gonorrheal infections. However, condoms don't you from all the STIs, genital warts, which can be spreading because of skin to skin. So efficacy of the on the proper use and dawning contact. We covered all these topics which you are, and biological, cognitive, behavior, and social and institutional, and hence also gone through the protective factors. Well, we have to that how does it that we can take care of STIs? They are very high risk. Focus on this STI care and that, and it's very important that you have the age to 24, and that is where the new further the doctoration in health and risk for other infections, HIV, and delay in detecting them to become a source of infection. So 5 P's are very important. Part genders, number, pregnancy, protection, condom use and practices, sex, anal, oral, and past history of. So we should understand this things.
So, Dr. Chavan, as a kind of multiple factors, you have factors, you have cognitive factors, and the biological factors basically the is there that exposes them more. The second thing that is there in the flora is also kind of cognitively, I think so one of the important concepts in medicine is this concept for they're not having sex with the same time. It's usually this 2 months, this person is my hero. Next month, another person is the hero. The other person is the hero. So they'll look for perfection, and that's why they kind of have serial monogamy. Also, at that, the protective mechanisms that are not what you talked about over here, a positive family, positive relationship with peers, and also, having someone useful. You talked about all these local youth groups. I think so. Those are really good things to do. I think so. In this section, we really need to do a better job. Proper history in India. We are so much, we are in the sense is that much of our patients, but at the same time, as parents, they're not looking to us as friends, to us as physicians. So it's important to be in a non-judgmental manner. It's critical. It is very difficult to be non-judgmental.
Dr. Paritosh, we yesterday had a very nice and the communication skills, which is a very important part of this.
Dr. Chandan, as you mentioned, I think it's important to know whether you're telling the truth or not. Important about it. Let's move on a little fast, but I just want to make sure that so we have Dr. Meenakshi Ahuja. You have a Jyoti with dysuria and potential diagnosis, and what additional information? Dr. Ahuja?
Yeah, I hope I'm audible.
Yes,
yeah.
yes.
So what happens is that in India, definitely, when a patient comes with dysuria, whether it is a problem with the urinary tract, so that's the first thing. We need to be more elaborate, be less judgmental, and talk to understand what exactly is the difficulty when she's peeing, burning in the vagina, or extremely important in these cases, and also helps us in gaining the confidence. So what I have in my head when someone is passing urine is that, is it a vaginal or a genital, or is it just something outside from this reason, maybe an injury, or maybe which I need to rule out. So I on those terms, whether if I'm thinking of she needs to wake up at night to pee, or often, is it burning, does it passage, or does it burn outside the skin? I would like to know that, whether there's any abdominal pain, whether there's any, because these would definitely point in the signs. If there's a vaginal infection, I think it's, if she's sexually active, I would like to know sexually active or not. Does she use protection? And if she's having any discharge, pain during sex. So these are the to ask. If the discharge is there, then definitely the story about what is the color of the discharge, foul smelling, and probably itself will lead me to where to go, and then probably go on with the.
Very much, Dr. Meenakshi. Just sorry, Paritosh, just make a little bit how we take the history of adult.
So I think so, Dr. Meenakshi, one of the that we do in India that is so awesome is taking a good history and examination. I think so. These skills are not, and my students over here, they know to ask us proper history. So the heads really a tool to have, like you said, going to the detailed history with home. You talk, and then you talk about substance use, suicide, and drugs, safe. So these are kind of important things to do. Important thing for adolescents is that you are okay to ask these questions. Asking these questions not to this. It's not punishment to trouble them. What you're trying to do basically is to find out. Right? Just like what you said. People. Dr. Meenakshi just told us. They don't know the discharge, and sometimes we just will test for vaginal stuff as well as things. So I think so. That's really. The other thing is just and to ask the patient is who is, and ask them everybody. So in our joint family, if the mama is there, the chacha is there, the is there. Those are important kind sources for that family member to talk about, young adolescent talk about. Don't under. Because that's a very strong thing that we have in our. Wherever little joint family is there, or even with WhatsApp, you connect with your uncle and you connect with your aunt or whatever it is. Just kind of build those relationships. It's do that and help them to understand. So I'm going to kind of, we are almost have the make sure that we kind of cover.
No, it's okay. It's okay.
No, not do the wrong thing if I'm expecting everybody. But
okay.
Important point, I think, Meenakshi mentioned, Dr. Chauhan also mentioned, Dr. Kumar also mentioned, is this history in the. That is where you're going to get % of your stuff. And exactly what I know the diagnosis by the time I've done my history only. Without the talking, but listening. जो हम कहते हैं हिंदी में ना, not just to talk. Sunna is very important. Quiet, and it's very difficult. Much, no? As doctors, you have to just move band karna hai and listen to them. So much information from them. It's okay. 2 minutes quiet in the day experiment. For one, you ask the question, which is a tough from the patient. Keep the phone for 1 minute. Keep quiet. बोलेगा ही आपको सच जो है. Learn to learn those skills. Going on, Dr. Chandan, नहीं तो यहाँ मुझे ना.
Yeah, you observe discharge. No, previous slide. Yeah, this one.
Discharge. Bolo.
Yeah. You observe discharge in the loss. You suspect vaginitis. What are this question is to Dr. Meena.
Yeah, this is a very common ruled out cervicitis. So we have in this lady who's presenting and a yellow discharge. So we can see of bacterial vaginosis, and trichomoniasis. These are the 3 types of vaginitis that we encounter. There are others, but in this the more common ones that we would find, especially the findings that you already narrated. Once having that diagnosis in the mind, we're looking at connecting it with the symptomatology of discharge, was going to lead a great degree to what we are looking at. She has itching, and are there signs of itching? Has she been itching? And then is it frothy? Is it green? Is it sticking to the walls? The things that we're going to look at. Then what kind of smell it has. So that was going to tell us. And with that, we can go on. If it is with a thick itching, we know we're looking at IDSs, vulvovaginal. And if it is homogeneous fishy odor, we know we're looking at bacterial vaginosis. If we have, again, itching associated with green, looking at trichomonia. With that, we can add on to some more simple tests we could have in our own chamber, and we are looking at, and then that is how these are the 3 we would be talking about.
Next. Was specially mentioned about the os. If it is at the os, they should have idea and they should think about gonorrhea.
Yes, Dr. Paritosh.
I think so. This is excellent. I think so. This, what Dr. Sama, this broad kind of over there, and then kind of looking at, so is UTI, is it a genital tract? Those symptoms of itching and odor, the color, what she mentioned. I think so. Dr. Chauhan mentioned it. I don't know. After we are outside vulvovaginitis, look for her. Someone mentioned the small introitus, so you want to see, just very gently have the sit over there. No need to put them in. Just kind of have them over there. Frog legs. Separate the labia. Look at it for abnormalities which are there. Keeping diagnosis is a good way to go ahead. If you see, as Dr. Bartla mentioned, from the os, I think so. Areas there, see chlamydia, and also what the original OBGYN physiology discharge if she's ovulating. So it is the might be there, and you don't know whether it's spin paracarditis. But the thing is that you should keep your mind things because both are possible. Good vision, but still you cannot or you cannot see the spin paracarditis. So that examine that way. Let's go to the next. So she's symptomatic, and if she's symptomatic, you will do the exam. Asymptomatic, do you need to do the exam?
Yeah. So about symptoms and types of most of the cases are asymptomatic if you actually trichomoniasis, and we have seen that there is a frothy discharge, or a patient complains to us with certain foul smelling discharge, and that's the time when so if she's asymptomatic but she sort of order, but she doesn't have to complain about it, but then she's saying yes of discharge, we will definitely speculum and we'll try to find out discharge, as rightly said by Dr. Meena. And if you see for the part, it's mainly the about foul smelling, frothy discharge, yellow discharge also, vaginal itching, burning, redness, now also dysuria again, and there will be soreness of the, so that's a little bit of a redness of the genitalia, of the soreness, and then or trying to clean it up, sensation. So that's very, very important. This is very common. We definitely check it up because also the sequel related with this it cannot be just kept untreated. To treat it, we don't know of the complications that are common infection. I know that the sequelae for trichomoniasis later on can be pregnancy. She, if it is untreated in that way, it can have a preterm delivery. Who have had, and there are also many times of comorbidities like HIVs and all that, all getting picked up. So it's very important for which type with and the right methodology of treatment for. I think I have.
Wonderful, really, really nice, Doctor. The important things is that these tips in the textbook, like this is green, this is white, this discharge, nothing looks the same, and these girls don't see, they just see that it really gets a little tougher to them. So, a trick, or what we call as over here usual lingo, we call it as a triple Sunday. Okay, chlamydia and trichomonas, all the three of them are. So we do this triple testing, triple screen for your prenatal. So here in STDs, we do a triple screen for GC, chlamydia, and trich. You have to treat accordingly, which we can go. Dr. Meena Samant, back again.
Important when you're treating. It's really important to treat well.
Yes, we'll come to that.
Yes. Actually, in fact, critical, and they have to wait days before they go and have sex again. Somebody is doing that. Okay, use the condom to work, because what happens with the able to use the condom effectively. To kind of in my practice, what we do is that we tell them 7 days you're not after your partner gets treated. You get treated after the all partners. Exactly, Dr. Anita's mentioned all partners for the last 2 months, because depending on this judgment, but say, how many people they've had sex with, I don't know. The people you've had sex with from the last 2 months, call them up, Instagram them, whatever you want to do, and get treated. And then 2 months, then for 7 days, no sex till that partner gets treated and sex with that person. And then
So much of a problem in India about so.
See, that is why I'm going to challenge us. I will challenge us because I think Western stuff has gone to Bombay, like
Yes, yes, Doctor. Also, these adolescents coming like Gurgaon. So here, the most of the adolescents are sexually active. I can't say about below 18, but above definitely they are.
With multiple.
That thing, but I'm just saying is that
I think from
yes, ma'am. Gurgaon, Noida, with the IT, lots of patients. Yes.
Here's where I think is that I feel rural India.
Yes, you are unnoticed. Yes, it gets unnoticed. Not with it. Yes, definitely.
It is so WhatsApp. How many videos are going on?
Yes, Dr. Neeta, you can you see in your community there.
Estimate them if you think that they're not having. I think it's so important. The age on wherever she comes from, urban, rural area, or even I mean, I think what Dr. Paris right with the advent of internet, all these videos going around, educated about what to do when there is a problem.
They get the wrong information from the net.
Nowadays, they're open about it, and I think you just need to have the conversation. I've had patients come with a guy and she's sitting with him, tell me that she has 2 partners. One I use protection with, one I don't. Sitting there. So, I mean, if you just think that it's in Gurgaon anywhere, it's.
I'm absolutely agreed.
We need to recognize it and accept it.
And accept it.
That's the important thing. As doctors, we can't move forward. We are there to help their moral science teachers.
You know, this is adolescent meant for. This conference was meant for this. To change the concept of it.
I wanted to say something.
Yes, Dr. Preeti.
Saying that the good thing is because I'm Mohali, so the very confident. It's more about art. They are very open about it. And
yes.
Acceptable to it. Yeah.
I want to say, Dr. Preeti and Dr. Meenakshi, I think you have said 2 pearls over here. STD talk or not, I think the truth is we have issues as
clinicians. Yes,
absolutely. We have brain. The toughest thing that I had when I came to the country, it was not, I knew PI exam, I could do it with my eyes closed. I learned to be truly non-judgmental. First patient in my first month, limited disease, 50 partners. That's what my research was. It was 50 partners, and I'm like, hey, children over here. But I now can talk about orgies and how many people are there in the sex, and whether the sex, the vagina, the rectum, or the mouth. We have to treat ourselves, and that is where I think I'm going to go off record. Dr. Ragini, all this work that you're doing, this is pioneering work. To change, na? We have the same old laga de or udari karo, you do just screaming on that on the. We've all done that kind of stuff, but tell this adolescent who's confident. Dr. Meenakshi is sitting in her clinic. He says, "I have sex with him with, and the other boy with condom."
It's very common, Doctor. Very common here now.
I
know. I'm telling you that.
Youngsters, because we have an app in Delhi called the Little Black Book, and it rates top non-judgmental gynecology. I had talks with youngsters, which says let's, and we have to understand that LGBT community also.
Yes.
That why is it that gynecologists lesbian, they don't understand. If I understand and all, and I have to explain to them, don't understand. So we are good at learning, and it's a process for us.
Indeed, we are talking about people who have crossed 18 years of age, less than that.
Yes,
So,
yes.
so
College
students. So, no, yes, college students, yes. You can say young adults. Yeah.
That gynecology, we don't know whom to go to because
Yes. Absolutely. So can we go to the next question now? Can you share us with the diagnosis and management of bacterial vaginosis, Dr. Meena? Yes. You unmute yourself. Yes.
Hello.
Yes.
Yeah,
Yes.
We have certain criteria. Bacterial vaginosis is it would be a little higher, more than 4, and we would get under the microscope, and 20%. Then we have the we put a drop of 10% QHC odor. So these are the things. Gram staining where you less of the so those criteria that we have, the Nugent's criteria, the staining. Then we have Candida. Just a second. We curdy discharge, what we talked about, the hyphae, then the pH less than 4.5, and of course a gram stain, WPCs that we encounter. So these are the things that, apart from, of course, the important thing and the signs as well. So that's what.
So we have Jyoti for that.
Thank you.
The interesting, everybody knows treatment of BV cannabis, but this.
Dr. Paritosh, one more thing. We are not talking about tuberculosis and HIV.
Yes. We are not talking about tuberculosis. We are not. We are talking about just good old
simple tests, simple
things. You know, like your bhelpuri kind of stuff. not going to a restaurant or having the chana chor garam. I don't know. Alrighty, so we are in this girl. This is a kind of quick thing. Note, and when I'm saying guys, I mean ladies and gentlemen. I think so. This is kind of chart which is there. The VIF test is there. VIF test can be paused. OPD, if you have, don't worry about it. Dr. Batla, the WHO has told us many times to be non-judgmental. Only non-judgmental is very difficult.
Very difficult.
First kind of time is when I did the STD talk, high school. So that was the toughest one because they said pregnant in the hot tub. Yes, absolutely. You have sex with get pregnant.
Next,
so, Dr. Priya Ganesh.
I had a resident who came to meet me at that I'm trying to get married. I'm not trying to get unprotected intercourse for 6 months. So is there something wrong with me? So I'm married to your partner. You want to be get married, but because lockdown is posted, I have no problem with that. I'm more worried. Why have I not got pregnant in 6 months?
So, this is another important thing, when patients, Dr. Batla's brother, what happens is some of the girls, you will tell them, especially in the States, we will have sex or the consequences of media and PID and going to get blocked, etc. What the here is key, I'm not going to get pregnant because of the STD. And so going to get pregnant or not, they continue having sex and they get reinfected. Yeah. So, the point that Dr. Bhatt, so, if you say the way very important, it's like, hey, the insect up. And if you continue to have sex, you're have more STDs and is want to make. You have to, like, you don't tell them to use a condom. Learned over years, you tell the patient, you sex without the condom more than.
Yes, because you
Do
are pregnancy.
If your patient, you say, but then that you take a, then it is you make a choice right now, or you want to have.
So we go to the.
Tell them, ki, I think you should know what it is. So behavior and two separate things, they are not together. To behavior, you have to do motivation. That is why the history is so important.
So important. We go to the next question. Yeah.
Please go ahead. We can see you. Can I
Jyoti, is vaginitis related to trichomoniasis? Dr. Priya Ganesh, please.
So this is coming up with the final diagnosis of, because you have displayed it on the screen itself. I'm going to give metronidazole as a 2-gram stat, or tinidazole. Now the alternative medication you have to give is 500 milligram B. Now understanding the fact that when you're of this thing, and even topical, now if there are treatment, we retreat it with metronidazole and BID dose for 7 days. Important point to be highlighted over here, treating the sexual partners. Now alcohol, so these people have to be abstaining themselves from alcohol.
Yes, that's very important. Yes.
And I really about alcohol.
Yes.
Dr. Priya, Dr. Ganesh, add is don't think the things they know more about alcohol than you are. So tell them, like, and it's, I don't know whether they're available in India, but these spice drinks, like there's alcohol, thoda hai.
We do have.
Yes.
We have.
Yes. So those things, alcohol, not if she's just a shot. Vodka shot only, even that other one.
Yeah.
Doctor. Okay, go ahead.
So, yeah. This is well, or is it for?
No, go on.
Okay, so taken up with a bacterial vaginosis. So we vaginosis. Now, if this case for vaginosis, again, you have the same thing as you not giving a stat dose, you will be giving a milligram BID for 7 days. Now, applicator, which when we are saying we have, many people know how to use, very important. So in our clinic nurse, who is a very high count that way, we tell them this. So might be the first application by my staff, who is also, and also would be, knowing it, how do you apply a valve later. Now we also have cream, so we have to do this. That's a one-time application, OD dose for. Now here, clindamycin in a BID or a QID doses have a very serious infection. But then alternatively, you also have tablets of clindamycin 300 milligrams. There's ovules, we have got this tinidazole per oral OD dose for 1 gram per oral OD dose. These are alternative medicines. These from CDC guidelines. This is what we have been giving and treating. Understanding the fact that these are, okay, now we have to also understand that infections have to be treated in a better way, and the partner is important. She might say that I have multiple partners, all the partners have, so that's what is written into the bracket, So you have to be very open. And yeah, the S, what is that? S? Have multiple partners, all the multiple partners. And then some might say, we don't have to use it. So no, wait. Even though you're using condoms, you have to, it's going to have a relapse. Now that's going to be then a resistant. Have treated her, and we do not a resistant way, to go.
Dr. One thing which was very long back when vaginal tablet. There was an application. So after 7 days, she comes back to me and तो दवाई लगाई नहीं, मुझे तो डर लगा, आपने पता नहीं.
Exactly.
So probably the counseling properly, and we do realize the point you raised that counseling is very important.
The other point I think so. For BV, we don't do partner treatment. The other point is, I don't know over there in this, but over here, especially when there's these fishy odor, which is more there, even in trick, but in BV, girls will sometimes go and wash themselves, and they will use some feminine hygiene.
Yes.
Typically known in the African American population, the do. So one of the things which you have patient who's coming with one second time, and you're like, "Tumne, I told you, make sure that they're not douching." And one of the examples is that the vagina is like a cell. So switch on kar diya, khud hi saaf ho jayega. Vagina also is that way, so don't need to kind of aura. That is an important concept. Trick, I don't know, one of the
Today's here, everybody's with a vagina and that Be Safe products, and they get lots of infections because of losing the vaginal flora.
The thing is also
all adults.
So here is the reason. The reason why people are using vaginas nowadays, men are performing too. So the girls that so what I actually I tell the girls, that vagina, there is nicotine in the vagina. When your boyfriend is going to having oral, or your girlfriend is having oral sex on you, she's smelling cigarette over there in your vagina, and that really scares them. But it is a good point to say, if you're doing weed or marijuana in the vagina, we know all the things that are secreted in the vaginal fluid. So one of the things is that all these feminine products could be that people are getting more empowered and wanting to have that, but just tell them not to.
No, we have to tell them that the overuse is not good. Next slide.
Next slide.
Yeah.
These are things of Canada. Doctor, move on.
We've already discussed. We've already
discussed. Canada partner treatment. Rarely, I don't treat my date the part. So let's go on to
the
Dr. Chavan.
Yes.
I think Dr. Chavan.
I'm very much there, and I'm.
Yes, sir. Yes.
बोला आता डॉक्टर चव्हाण सांगा.
बोलायला देत नाही, मी बोलायला गेलो तर तुम्ही स्वतः 15 मिनिटं बोलले.
थँक्यू.
असं नाही करायचं, आमचा अपमान नाही करायचा. जेव्हा आम्ही बोलणार, आम्ही जसे आहात तसे बोलणार. जेव्हा तुम्ही बोलणार तेव्हा आम्ही गप्प बस.
Yes, sir. We go ahead.
So you should understand that people are coming to congratulate Ragini Agar, right? You just. I did not like that.
Sir, we'll come to the next question. Jyoti is sexual. She is also at risk of cervicitis. What are the identifiable causes? And briefly tell us about the chlamydia and gonorrhea.
Yeah, actually, there are many slides. We are already aware that it is chlamydia. Girls which are there, they visit our clinic. We have to understand two diseases which can cause infection. So it's a STI. First, we will talk about, and see me also.
Yes, sir.
90% of them are in females, but spotting dysmenorrhea, dyspareunia discharge, and when they have infection and penile discharge. So understand. Next slide, please. Now what do not treat them, or they, the next thing it affects vital organs, and that's what in PID, and that's 10 to 15. And furthermore, it increases transmission. Next, please. Recommend for the routine annual cleaning. These are the organized, and that's what they usually recommend, that women above or less, or rather I would like 25 to 24 years for this screening. Next. Now let's come to gonorrhea. Is more commoner than, it is also a curable disease. It's more reported. It affects all the genital system, but also in the mouth, throat, eyes. So we have to understand that here, instead of 80% asymptomatic, here 50 males and females are asymptomatic and symptomatic. What they have is the discharge, vaginal discharge, and it burns. It has a painful urination, pains of bleeding with vaginal intercourse. While in males, greenish type of purulent from the urethral orifice during maturation, and even if the symptoms are more swollen and painful testicles. So what are the clinical manifestations? Them on examination, you find that there is an inflamed urethra and the cervix inflamed, but no symptoms, and you put a speculum, and so that is what you have about gonorrhea and chlamydia. And the worst scenario, married, they have pelvic inflammatory disease. It's an acute episode of a in nature. Every 2 to 3 months have these issues. You have ectopic pregnancy. There, it can also cause you an immunocompromised state. And in males, prostate involvement.
Next slide.
Also, the involvement of other organs. So it's very there are certain screening, all the sexual active.
Paritosh will go a little bit faster now.
Yes, I'm doing fast as I can. Run beyond this.
Yes, sir. Please.
This is what you have to understand, the risk of 15 to 24, and in males it is 20 to 20. We have to understand that there are certain which is there, and you have sexual partners, history of coexistence. They are taking drugs, militant. And how do you evaluate? My topic is over. I think Dr. Neil.
Yes,
and
sir,
I
yes.
would like to thank all of you, Alpesh Gandhi, Madhuri Patel, and Dr. to invite me to this conference, this wonderful there. And with this, I would like to thank you so
sir.
much.
Thank you.
All the best to job is over.
Thank
all
you,
the
sir.
best
Thank
to
you.
Dr. And thank you, Dr. Kaul. I will see you in person.
Yes, we'll see you in Mumbai. Mumbai मध्ये भेटणार.
So Dr. Nirja with Jyoti for service-itis. Interest also.
It is, thank you. And, the thing is that now we have, first of all, has been sexually active. Once they are sexually active years, there comes the other aspects as well. First, let's talk about the problem she has and see how we are going to test. So it is self-collected vaginal can be done now, and even can be done, although their performance is with the genital swabs. Taken for the nucleic acid test, and now in the COVID era, the NATs in any case. Yes. And they compare well with the culture. And in fact, the detection rates are significant in the culture. So the culture is a thing of the past. So I think we can do this one, which shows that basically they are much better to do the NAT. Even in the males, it is a better one. So
just a minute. Yes, ma'am.
Please continue.
Please continue.
So no, I think this question is now passed to Priya now, that if there's also a concern, of course, in case it's necessary to check for the pregnancy, what else is to be done now?
Yes, Dr. Yes, Dr. Priya.
NAT test has really now taken up doing NAT test in India as well. As Dr. Batla said, has been now when we collect the sample and else also can we do is also that time counsel her for an HPV. Why not also see her HIV? You know, we do not know, it might be hidden. And we talk about all these things collaterally when we are also treating her. Now pregnancy, now adolescent pregnancy, you know, because this adolescent, she might not know, and then there's unwanted. We don't want all those things to happen. That's what we do. That's the thing with bullet point, which I wanted to highlight. This video do is the third bullet point. Talking about the treatment, I think be continuing this, the treatment, or
I think Dr.
No, you can continue, Dr. Ganesh.
Yeah, so the treatment when we go about, say it's out over here displayed onto the screen. These are the CDC goals and CDC. And what we are talking about, why are we talking about? Because there has been of resistance, and the concerned about now the resistance occurred because of gonorrhea as well. Part mainly. So the two drugs out is with Cefig, actually, if not available, Cefig goes along with that. Is in 1 gram. Orally, that's one. Again, no, some people have an allergy. Then we give a doxycycline BID dose for 7 days. Now, test of cure. Now, why do we have cure? Again, I'll come to that as well. Now, understand, like, suppose, now, first, we can have the next slide, please. Very important topic, very big topic if you go to CDC and if it rates. So, the ceftriaxone 250, it's a single intramuscular dose plus mycin or doxycycline. Even though, you know, the quinolones, but still we are seeing, we are recommended in the US for treatment of conditions. That's one thing which we were 2007. Now the treatments which we give, usually there are drug resistance or there are, that time it's a time when you give straight 2 grams orally once. We're talking about adding or ceftriaxone with mycin. We have now taken up 2 grams. Now here, test of cure. Now this is very important. This concept of test of cure is enforced also in a better way. Also, we'll have to know this, that this is better. Because if it is an alternative regime, and as the symptoms, many isn't it that people come to us ki nahi treatment barabar ho, I mean those symptoms, and whether it's a reinfection or whether it is being not treated well. So which is written over here, see, and this is the NAT which we do most negative, of course, but then we repeat this once regardless of the prescription as well. This is very, very important. Next. For us to know. Continue or
A few points. So one of the things I think, so that's the test of cure, treatment of the partners, pharyngeal kind of GC also is important. The thing is, I just want to kind of go is that if you have for chlamydia, if you have chlamydia, you don't need to, at least over here, the way the symptoms are. Erythromycin is basically over there. Really nice point about, symptoms are still there. One of the things I avoid using doxy for 7 days, really nasty drug, taking it ID, no, none of the girls are going to, and that is why they're coming back. Treatment has not worked. It means the compliance issues there. You should talk to patients really directly. 7 days tablets, I think so that is important. And regarding the symptoms of it,
the prescription, I asked them to get kits.
Nice.
For me, that's one. See that compliance is being kept.
So, and then the
Can
other
we have
thing
the next slide, please? Yeah.
Okay. So we are not going to go to.
Let's come to the HPV vaccine now. I think.
The HPV.
Dr. Latika's question now. Before
approach is also very important.
Yeah.
Yeah.
Dr.
So
Neeta?
I quickly about what's the syndromic approach. This is proposed in 1991. So there was putting all the signs together of the common organisms which cause cervicitis and about in the past right now. We put them all together into three. So the genital syndrome, the urethral discharge syndrome, and there is symptoms which take you talking about symptoms like one of our when you're taking history, you almost what the diagnosis. But you go through the algorithms, you come to a conclusion that this may be that. Clinical signs which are very nice syndromic case management, conclusion that it could be this or that. There is a very nicely colored package treatment now taken over by NACO. So NACO packets here. So the National AIDS Control Organization put together this syndromic case and has distributed this concept to even primary health center. A trained person who is good or she is basically a health worker in managing this, and it's excellent. Is a very
approach.
Good approach. Yeah, there are the only and it also takes. It's simply not giving you after examining and taking history. You are also educating the patient. You are counseling them. You are patient partner treatment, and you refer them to these integrated centers for treatment. That is for HIV. There are two things which I really want to make. One is the advantage is it's simple, cost effective, satisfied that you didn't do any treatment, you didn't investigations for her, so you've cut down on the laboratory investigations and everything, and it gives her a patient action. But the disadvantage is antimicrobial resistance, over treatment, and it's a subject. I might see a discharge and I might tinnitus, or I think it looks like this, but it's a subjective which we are doing.
Still, so, it gives a bit.
It gives it, but the biggest not like so many of our speakers panel. So much of this infections are asymptomatic. So asymptomatic, you will never find organism, and you will miss out on that. So diagnosis comes in, but then it's an excellent management. I want to mention what I do in my clinic about ceftriaxone having single
azithromycin. So we just to give the girl the medicine. We say, okay, you have the single dose. Half the treatment is done at the dose is given right off the nurse. She gives her, why don't you just take this? So we are help in compliance. So it's a very
Thank you
method to manage.
Much. There is one question for Dr. As a pediatrician, if a less than 15 years with come to know that it's a sexual assault, what is your approach?
Yeah, whenever we have a child come to you who's less than 18 years, so any child who it will POXO Act. So we have to see what is the POXO Act. So for the important child, it is important to we have to first we have to ask whether this you had already written about a girl. So if the girl is already and she has gone into a consensual, whether it is a consensual or consensual was under the effect of alcohol, the child comes under the POXO Act. Mandatory reporting is very, very important. The reporting is the most important to understand. We have to make be aware of the situation. We have to inform the mandatory reporting to the police. We doing the mandatory police. It is very important that that we are doing the medical, taking the medical history. So totally in a non-judgmental manner, be in a very empathetic manner, so that including the mother also has to be explained, and the parents are not for it. For doing the mandatory reporting, we have to explain it to the child, mother. If we do not report, the child may be in for a more trouble. So in that case, also
but before you start getting judgmental police, and the patient doesn't. First of all, we have to give
first
to treat
all,
the as well.
So first is the emergency medicine.
Yes, that is very important. Police to give the treatment.
Informed consent, important medical reporting is also, and the first important thing is care of the person. So if the child is, if the child requires some kind of if the child requires, there is some like the child is already affected by the whole thing, we have to have a proper history,
treatment. Thank you so much, Dr. Latika. Dr. Batla.
Very important, which we have had so about is that if it is according to POXO, she is not to be examined.
Yes.
Because you can just do the basic perfunctory examination to see if there is issue, but aside of that, without this is very important. One went right up to DMC.
5 minutes this. It's now, and Dr. Nirja, this case.
Okay, so you go very quickly through if we have only.
I have to give 5 minutes to Dr. Preeti Jindal.
Count the time, just fast forward it, because you see external genital, most common thing we see, and molluscum is also. So of course there are a vast, we have to keep in mind. We have to also keep in the condylomata, and but most common now is spots, which are usually, if it is the benign type, the low risk type, 611, and of course we are as much concerned with the problem, but we are also concerned that she may risk HPV infections, which could later the cervical cancer, vaginal cancers. So it is transmitted infection, and human infection, it is estimated that males will acquire this infection in their lives, and although peak sort of in third decade and most but in India we don't really see. It's more flat that we see over here. Of course, this is showing you of these. So what is as much a problem in India as it is in many parts of the world. But again, there are pockets. Some areas have less. So we have typical sort of a description that is here. The condylomata acuminata, which is shaped, fresh colored look, the smooth pop, which may be dome shaped and skin colored, sclerotic warts, which have a thick horny layer, which are macular to slightly fresh colored ones. And they could be anywhere. They could be on the vulva or the anus, and they may come accordingly based on where they are located. The diagnosis can be done inspection, acetic acid, vulva, because it's a thick skin and up so well. So, and even it up, it doesn't really management, so to speak. Not usually recommended unless they are worsening or they are ulcerated or there is a very irregular pigment. You can do it. Now, screening guidelines, you know, I've of the FOGSI guidelines, which find a lot of effort from a lot of people, like everybody who is in the audience, because this has been made very pragmatic, high resource, depending where you are working, depending on feasibility and problem. So they are in tune with all the Western guidelines, other countries guidelines, and made it according to the level of evidence as well as the impression of the experts. You will see that all over the world, screening of girls is done away with, irrespective of. If you have it done, you will pick up a lot of lesions anyway. You will cause her psychological pressures that she now has a problem, and you will treat which may not require to be. Most of these lesions would require the next 2 or 3 years, and through treatments you could cause problems the and in fact screening under 30 is not recommended, not with under 25 in any, we say, for even high resource, because hardly any before that time, and mentioned it. Next,
just a word vaccine.
So I think we have some slides down the line.
Just
we have
round it
types in India. The quadrivalent, non-avalent has been licensed, but because of reasons of come till 2023, since the bi and the quadri are not, so that is off label in this country, and any vaccine is in short supply, so try and focus on the younger girls. The goal is to give her first dose before. After that, you can give her 6 months, and even if you year or a year and a half, it's, in fact, WHO says you can even give 1 dose before 15 and 3 later, because there is very promising on the significance of. So that should be our target. The problem is adolescents sometimes feel, I've had vaccine, I won't get any STD.
Important point, yeah. That's very important.
Preventing STD.
Yes, that's very important.
That counseling is really.
Thank you so much. That is really important what you mentioned about the HPV vaccine. One of the things that you and FOGSI should really do is to get the HPV vaccine for the boys, because as we know, you know, there has to have male and female, then there's sex.
Yes.
Female, male also is sex. But I think so, to decrease this HPV, you know, and always the focus needs to be on the male also, because they are also, they are having sex, and
yes,
we care about women. That is why we have to take care of men, and that will increase your kind of guidelines.
Thank you so much. The next question and the last question is for Dr.
I'll just take a moment of
to
say that we have the Indian vaccine coming in phase 3 trials from Serum Institute, and they are testing it for the males as well. So once they find the males, then they will get licensed.
Thank you. Next question, and the last question is for Dr. Preeti Jindal. Dr. Preeti, you being a urogynecologist, so you can throw some light on how to treat genital warts.
Yeah. Quickly wind it off that, and we rushed as I rushed the
because she's getting.
Yeah.
Yes.
So the main thing is that there are treatment. One is the surgical and other is treatment. The medical drugs are all. One drug I would really like to say is the Gilligan spray, and I've got very good results. Just a spray form thing, and you can just. And secondly, if we go for the surgical removal, shaving, curettage, can be used. But one thing which one careful, if you are using any thing, please do your suctions well. It will be in the plume of the smoke. Safety of the and also could be cervical warts, vaginal warts, urethral, perianal, and again the treatment. And hopefully, I'm really hoping that with these, the number of warts which we see are decreasing. Just one, we see a lot of wart infections. Not that yes, we see a lot. And I just want to know one thing: that in males, are you using the same we are using for females here in India?
Yes,
Dr. Preeti, something.
We're using the same Gardasil. We're using this, and also like what Dr. Batla mentioned, we are doing it at a younger age.
Single dose.
Sexually activity, and when for recommending only 2 doses for our first dose, then we give them 3 doses.
Same here also. Yeah. Dr. Preeti, what about the laser?
I love the lasers, but not with the active. Once I treat them, and then after that, residual, some residual things, then we can laser. Then you have to be very careful that the smoke will have the viral particles. So you have to take all the.
Adolescents also think that warts taken the Gardasil injection, now they will go off.
Yeah.
Then they again go for the indulgent sex. Then we have to counsel them for this also. So this we have discussed already. So just wind it up and finish the last comment.
Let's like we've done. Let's do a speaker view, or what is it called? Gallery view.
You can have a gallery now.
In the gallery. So first of all is that 1.5 hours, everybody needs to go to their life, go on. But first thing is, important concepts to take back is this happen with every social. And one of there were some chats were really awesome. I'm so like rural, urban, we all are sitting over here sex with somebody else, right? If we had not had sex, we would not be alive.
Yeah.
Understand, sex is universal. Started off weird from the age of Kama Sutra. Hesitant about talking about sex.
Yeah.
Talk about sex positively. If you tell a boy or a girl that sex is an awesome thing, they're like, "Arey." So, in a safe relationship, in a committed relationship. So, to kind of go tell your patients is sex is positive, but sex needs to have responsibility. Do you want the response? So, thank you, Dr. Preeti. Good job.
It was an excellent panel with the superstar and excellent celebrations. We have learned a lot. So much. Thank you, Dr. Paritosh. We all ladies have taken from his very. He has slept at 2 o'clock. Sorry for that, Dr. Paritosh. Thank you so much, Dr. Ashok.
And anybody wants
thank you so much. Thank you, Dr. Chandan.
Sir, a word about panel. One message, sir, Dr. Sir, unmute ho jaiye.
Only message we want to say about adolescent is special group, and we have to provide special non-judgmental.
Yes.
Thank you.
Thank you so much. Yukti,
Yeah,
where are you?
thank
Yeah.
you. Thank you. It was a fabulous session. The last session, and yet so many. And the good news is that we've had around 6,000 today.
Wow, wow.
Wow.
And
Beautiful. Shares.
so it's 3 cheers, right? So one, all the attendees, if you're still hearing me, click on the survey link on your screens and survey. So please do fill in right now.
In the
Please
chat
do fill in.
box?
No, ma'am, it's for the attendees. Yeah. So below the comment section, there is a link. So please do that. Request Dr. Anita to please. Thanks. Dr. Ann has served in various government and positions of repute in Delhi. She's a very senior gynecologist and a specialist. And ma'am has high-risk pregnancy and pelvic surgery. Thank you, ma'am. Dr. Anita, ma'am, are you there? Right, ma'am.
Good evening, everyone. Congratulations, Chandan and Dr. Paritosh panel on STD. Now we come to the end of this e-academic bonanza. Great knowledge sharing all the 3 days. Each day set the new excellence for the all and on the adolescent health. I feel honored. It's my pleasure that in the most difficult task and end of the wonderfully organized econ has been assigned. The world has changed so far in 2020 that we all are meeting and interacting on a virtual platform. And that is the true adaptive society, our FOGSI society. Leadership. Without holding, it's my sacred duty to extend gratitude to our national FOGSI, Dr. Alpesh sir, and Secretary General FOGSI, Dr. Jaideep. I also thank and congratulate whom we adore and put Gurgaon on national map. FOGSI and my mentor, Dr. Ragini. She is always there in our of every. My sincere national coordinators and conveners, scientific committee chairpersons of this. I'll just name a few to name all. Mukherjee, Dr. Razal Thakur, Dr. Samant Kumari, Dr. Niharika, Dr. Rohan, Dr. Susan Williams, Dr. the scientific chairpersons, Dr. Ashok Kumar, Dr. is the backbone of this along with Dr. Ragini, Dr. Shakuntala Kumar, Dr. Deep, Dr. Pramila Malik, Dr. Saroj. Thanks to all this. I thank the National President and the Office Bearer of IAP, Dr. Bakul Parekh, our Secretary of Gurgaon IAP, Dr. and Dr. Anurag Singh. Office Bearers and Executive Board were on Haryana OBGY stood firmly with us. My sincere thanks to our GOGS team, our GOGS President and Secretary, Dr. Subohi Rizvi. My sincere thanks to organizing members, pharma, and other industry partners, support team, event managers, to all the speakers and faculty chairpersons who have made big success. Last but the participants who are the soul of any success. A big thanks to all. My special thanks to Mr. Neer, partner who managed and this coordinated this conference. Thanks one and all. Forward for more of such events. Wishing you all a safe and take care of yourself, your staff. Love you all. Long live FOGSI. Jai. Thank you.
Dr. Agni, one word from you. Dr. Agni, one word from you.
Wants to take a nap.
We will sleep after so many days. I was thinking.
Participant, I am over in the 6,000 people has joined.
Great, so
Thank
great.
you so much. Thank you. And one thing more which I can say is my thanks sincere to everyone. Anything cannot be by one person until unless you have a person behind you, and there's so many day and night, and literally silent worker behind, and the all glory is given to people who are in front, but they are heroes of the thing. Thank you so much, everyone, and especially Gox and her. I bring, and they're always there for me. Thank you so much.
3 cheers.
Thank you. Cheers for you, ma'am.
Yes.
Who has come for a very, very small part for the 2 minutes, but they have joined. Thank you so much.
Nirav, a big applause for you for managing this well. Technically, no problems at all.
My pleasure, ma'am. My pleasure.
It was
Face.
from all, nationally, they have given you, 3 chairs.
Yes. So you've done an awesome job, Neerav. To all my friends in India, FOGSI still just as an
Niro can reference also Dr. Paritosh from here. So
no, he wants to do my conference bowl, so we will call him in the Super Bowl. I do nothing of that kind. But awesome job, and if there's any way I can, just please let me know. I think so. You as a very, very important part to play of our teenagers, and don't underestimate that you and you make a difference. And previous panel discussion is we have to educate. People educate, they're going ahead, but we will not be able to talk to them.
Yes.
God bless
thank
you.
you
We'll
all
catch up.
Thank you.
Behind, because very necessary part of us supported us. Thank you so much.
Thank you.
Wonderful.
Thank you. Thank you.
फिर मिलेंगे. चलो युक्ति अपन दोनों भी
Yes, ma'am. Ma'am. Good night.